I am honored to moderate this session this morning, and I am thankful to the SSBMT and SSH for involving me in such a role. Today, we are going to talk about important subjects, and we have very interesting speakers. Our first speaker is my colleague, Dr. Ammar Hassan al-Saghir. He graduated from the King Saud University in Abha and also did his postgraduate residency training at King Saud University in Riyadh. He did the King Saud Fellowship in Hematopathology, followed by advanced training in Canada in neoplastic hematopathology and transfusion medicine, bone marrow transplant. He's currently the head of transfusion medicine in King Fahad Medical City in Riyadh. His interests is in transfusion medicine, and he is one of the experts of transfusion medicine in Saudi Arabia. It gives me a great honor to introduce him.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank Dr. Muhammad, my dear friend, for this sweet and nice introduction. And I would like to thank the organizers for inviting me to present in this prestigious conference, combined conference. Today, my talk will be about plasma transfusion. And plasma is one of the products that is considered in the developing worlds as a precious product, and it is used, but every ml of it is used for fractionation and for plasma industry. And we are one of the developing countries, and we are soon going to adopt many plasma manufacturing strategies. So many guidelines and many strategies to limit the inappropriate use of plasma have been developed in the developing worlds and worldwide, and including our countries and regions. And today in my presentation, I will. This is my center in Riyadh. King Fahad Medical City is one of the largest, is the largest MOH site in the kingdom, and has 1,200 to 1,500 bed capacity, including cardiac, oncology, pediatrics, women specialized referral centers. I will talk today about some of the plasma products and the available products in the country and worldwide, and I will talk about the plasma dose and volume and utilization, and some talk about the appropriate versus inappropriate plasma transfusions, and the effect on coagulation test, and some other information. This is the plasma you keep in your inventory, frozen and -18. It comes, this plasma, it comes from many sources, but plasma and plasma-derived products are used for reversal of coagulation, or used as replacement for in therapeutic apheresis and preoperative surgeries, part of protocols or massive transfusion. Prothrombin complex, I'll talk about it a little bit in the middle of the talk. I will not talk about cryo and fibrinogen. So the plasma that we have is it comes from many sources, either apheresis, the apheresis donor sit on the machine and we collect 500 to 600 ml, or we get it from whole blood with an average volume of 250. Some of the plasma that we have is pathogen reduced, and I'll talk about it. Solvent detergent is manufactured in the it's under pharmaceutical industry and manufactured in a few countries worldwide. The single donor, or one, the plasma that we store in our inventory come from one donor. So this plasma that we store come from one donor, and the volume variable. If it is single whole blood 200 volume to 600, it is under local manufacturing practice, subjected only to testing and donor selection practices. It is readily available if needed. With the available technology is very simple separation technology. The safety margin of this plasma is not 100%. It's missing another safety margin like pathogen reduction or viral removal. So and also its volume is dependent on the availability of the donor. Sometimes you need AB plasma and the number of donors are not available. So safety is a little bit in the disadvantage side because of the technology itself. Compared to pooled plasma from which we import from manufacturing companies like Octapharma, for example, Octoplus. This is a pooled from many donors. Whenever a lot number contains maybe 1,000 liter pooled together and goes under heavy manufacturing process with regulation and the number of coagulation factors, the viral inactivation, and subjected to and added to its solvent and detergent materials to remove all lipid and non-enveloped viruses and bacteria. And it is very good because it added a safety margin, which is the viral or pathogen removal. This the availability is very good. You can import as many as volume you want, but it is the disadvantage. It's for any supply chain interruption. This can interrupt your supply. For example, during COVID, some shipping, some regulatory or donor issues. So a disadvantage compared to the locally produced plasma. BRT plasma has both advantages. It is locally produced, but subjected to in-house pathogen reduction. We added some materials to the plasma and platelets and the other if we need it. So this technology applies to plasma and platelet. But now, for the sake of platelet, the amoxicillin or the riboflavin, these are materials added to the plasma, which will intercalate with the DNA of the any cellular material, whether it is pathogen like virus or bacteria or leukocytes, and upon subject or upon exposure to the UV light, this activate this molecule, the amoxicillin or riboflavin, then it will degrade or inactivate this cellular material, which is viruses or bacteria. The same volume that is locally produced plasma, but has another safety margin. Intercept is FDA and CE approved compared to the riboflavin, which is not the Marisol, but they are both available in the market. Solvent detergent plasma, which we talk about, and the methylene blue plasma, as we talked about, it is some material. The SD plasma is added to the solvent detergent material is added to the plasma, then it will inactivate the bacteria and virus. Same with methylene blue, which is used in few countries of the world. This is prothrombin complex concentrate. Is a plasma-derived product under manufacture or pharmaceutical production, lyophilized material stored in the pharmacy, not in the blood bank. It has balanced coagulation factors in a ratio of 1:1:1, which is 2, 7, 9, and 10. It has good amount of the other therapeutic levels of protein C, protein S. It is used exclusively for reversal of warfarin overdose, to reversal of this vitamin K antagonist. What the advantages of the similar advantage of prothrombin compared to the plasma? It is pooled, virally inactivated, safer brine reduction process. Overall, it is safer than the plasma, especially the locally available plasma, readily available in the pharmacy. No overdose, volume overdose. Like you have to give 1 liter in the plasma. Maybe you need only to give small amount of only mLs. Cost-wise, it is the same if you compare it by dollars. These are the therapeutic indications for plasma, and in general, it is either for whenever there is a bleeding with the coagulation factors deficiencies, multiple coagulation factor deficiency, like we see in DIC, liver failure, or massive transfusion, or substitution therapy for single coagulation factors where it is not available, like in the middle of nowhere, where you don't have any factor 8 or factor 9. So plasma is available, and it will give you 1 unit per 1 ml as a dose. So it's also used for rapid reversal of anticoagulant, the warfarin, as we talked about, if the prothrombic complex is not available. Also, it is used as a replacement fluid for treating TTP as the category 1 indication. These are the doses of 10 to 15 ml. These are the blood group availability. We don't respect the RH, we respect the blood group, the ABO group only, where AB is the universal donor. So plasma transfusion guidelines exist in many countries of the world, including our country, where there is a new guidelines have been published recently. It includes some of the plasma indications, but these many transfusions, many plasma transfusions, if you compare, judge it against the guidelines, is considered inappropriate. If you go by INR, if you go by whether there is a bleeding or not. So these are the this summary of the many audits done worldwide for the plasma transfusions in many places, and these are the number of transfusions, and the percentage at the end is the percentage of transfusion that was considered unnecessary based on their guidelines, and you can see it up to 66% unnecessary in the lower reference, from 30 to 60% considered unnecessary, and we'll talk about it a little bit. These unnecessary have important effects. This plasma is not without side effects. It is a fluid that is blood derived, that has all the complications of a blood transfusion, and in higher proportion because the plasma unit, the number of transfusions is usually very high. You give 5, you give 6, you reverse bleeding, continuous. So sometimes one patient can get 4 to 6 units of plasma. So you multiply the risks by 4 to 6 times and maybe more. So these are some of the adverse reactions or adverse reactions and complications like any blood products, but in higher degree, like allergic reactions. And many of them are unreported or underreported. And it is a huge discomfort to if it is reported, then a lot of work to investigate, to work the patient up. This is costly for the system. Why to transfuse unnecessary products? Trali, this is plasma, volume overload, HIV, viral transmission, citrate toxicity sometimes. So the guidelines for plasma transfusions published by many national and professional organizations for many years, they are non-evidence-based or lack sufficient detail. The typical recommendations, such as those put forward by Canadian, only very general recommendations, not very specific to limit the unnecessary transfusion. Also, recently, British Committee has published their guidelines. We'll talk about it a little bit. So these are the guidelines and recommendations, and all, as you see, they are talking about bleeding or significant prolongation of INR. With the significant prolongation, we are talking about more than 1.8 in many references. With bleeding, I cannot argue whether it is, when there is a bleeding and there is a good evidence that there is a plasma indication, it is a very solid indication. It's also with the prolongation of coagulation factors. the British guidelines, they're talking about now we'll limit our discussion on the we'll go to the inappropriate guidelines. So this is another guidelines are talking about prolongation and bleeding of bleeding with or without bleeding or prolongation of BT and BTT. Also plasmic chain for TTB or QS or antithrombin, other small indications. But the bulk, this is the bulk of indications we encounter on daily basis, bleeding or prolongation of INR. TTB is when one patient will consume all your inventory. So this is a very big user or very big category. There's also massive transfusion. A massive transfusion now after this research coming up, the including of FFB in every massive transfusion protocol with a 1:1 ratio has increased the consumption of plasma in these days. So what does INR and BTT results mean in coagulation factors? So what prolonged BT and BTT, when it is prolonged out of the normal range, this means that the coagulation factors has fallen below 30 to 50% of normal. Similarly, this is overall. So whenever you see prolonged, and so if it is not prolonged significantly, you mean very good. You have still the patient have very good coagulation activity. Same thing. Whenever the similar effect. So the goal of this FFB transfusion is to increase plasma levels above 30%. Usually, with a dose of 10 to 15 ml of plasma, will increase coagulation factor to this level and will treat any bleeding due to multiple coagulation deficiencies. So now talk about the appropriate and inappropriate indications. The most frequent reason for this inappropriate order is to a correction of a prolonged INR. This prophylactic correction of minor laboratory coagulation continues in the absence of any evidence of benefit. So I will talk now about this study who looked at the FFB transfusions critically ill patients. Almost 32% were consistent with the guidelines. The 20% were inconsistent but appropriate. Maybe there is a bleeding. Almost half were inappropriate. So to talk about this, the inappropriate where the patient or they have low INR without active bleeding and he is not going for any surgery. And we did a similar thing in King Fahd. We have 1,000 FFB audit at King Fahd Medical City, and we look at the indications, we look at the INR, whether there is a bleeding or not, is the patient going for surgery. We excluded the plasma exchange, we excluded the cardiology surgery because this is part of their preoperative protocol. So at the end, I found these two slides similar to the previous study. So we look at those with, I looked at given plasma for the sake of INR only. And this is the last slide. The plasma was given, and we adopted the guideline 1.5 and INR less than 1.5 considered inappropriate, above 1.5 considered appropriate. As you see in this, in the right-hand graph, the number of inappropriate patient has no bleeding, he's not going for surgery, and INR was less than 1.5 constitute 72% of this plasma transfusion. These patients, those who have high, this is the inconsistent with the guideline, but considered appropriate because the patient has bleeding, for example. And the proportion is 42% are less than 1 point R INR, but the patient has, maybe has a bleeding or maybe going for surgery. Similar. So we are facing the same issue, I'm sure, with every center available. So now, what will the FFB unit do to this INR? So in the right, in the top bottom, the pre-transfusion INR from 0 to until 10. So after giving plasma, how much this will correct the INR. See, this is the axis column. So 1.0 or 1 or 2, how much drop of INR from the baseline? 1 minute. So if you look at the INR below 2, too little effect on INR correction with the 1 unit of plasma. So this is similarly, see how if in INR below 1.6, almost no effect after plasma transfusions. I have only 1 minute. So this is the Society of Interventional Radiology. This is a very, very big category of patients who receive INR for pre-procedural, you know, our interventional radiology, they want to give FFB. So this is these list of indications with an INR of 1.5 or related more than 50, no need to give FFB. The British Society of Hematology, they endorse this guideline, the Liver Society recommendation that prophylactic transfusion of FFB and cryo is not given in low bleeding risk patients, such as paracentesis or others. This is the correction. So now plasma was used as, we talked about plasma as coagulation replacement. Now this is plasma as an immune replacement. Immune replacement, and after COVID, we did participate in this study, and this FDA have published or issued this emergency use of convalescent plasma. Whether you agree or not on the final recommendation, many studies have concluded that maybe it has little or no benefit of using plasma, but it is proof concept that plasma is, if the industry will improve, plasma can also play a role in fighting these diseases. It did prove benefit in the previous MERS. Inshallah, maybe the technology will improve. So this is my final slide, and time. Thank you.
Good morning, and welcome to the first session of hematopathology. I am Dr. Arij Al-Mughairi, and it gives me great pleasure to moderate the debate in this session about the necessity of thrombophilia testing. So the first speaker for this session is going to be Dr. Mohammed Al-Badr. He is hematology and thrombosis specialist at Al-Ahmadi Hospital. He was the head of hematology unit at the Sabah Hospital. Dr. Al-Badr obtained his medical degree at Al-Kuwait University, and he subsequently completed his fellowship training in adult thrombosis medicine at Ottawa Hospital. Dr. Al-Badr, he's going to make the case in that debate about necessity of thrombophilia testing. Dr. Al-Badr, the floor is yours.
Thank you, Dr. Arij, for this kind introduction, and thanks for the organizing committee for inviting me to this conference. Today, we have a very debatable topic, actually, thrombophilia testing, mostly because there is no evidence-based or strong evidence-based data on this topic, and also because there is no randomized controlled trial. Also because there is no randomized controlled trials on this area. So what I'm going to do in the next 15 minutes or so is to First, I don't have any related disclosure to this topic. So I'm gonna elicit 4 or 5 cases around this topic, and we'll see whether thrombophilia testing would be necessary to be done on those cases. So first, I'm having a 67-year-old man who has multiple comorbidities, who had a left leg DVT for 5 days, and then he had delayed right hip replacement surgery, and then had initiated thromboprophylaxis later, and he developed DVT post-op. The second case about a 28-year-old woman who had an unprovoked DVT without any provoking risk factor. The third case about a middle-aged man who had an abdominal pain and had a portal vein thrombosis with high hemoglobin of 19 gram per liter. The fourth case about a family history of a strong family history of VTE for 2 patients who had one who's counseling about using OCP and the other about the risk assessment during pregnancy. First, thrombophilia is a hereditary or acquired condition that predisposes patient to thrombosis. And this can be divided into acquired and inherited. So the most common inherited are the antithrombin protein C and protein S, and they are called strong thrombophilia. Factor V, Leiden, and prothrombin gene mutation are called weak thrombophilia. It is important to also concentrate on the acquired thrombophilia. We have the phospholipid antibody syndrome, myeloproliferative neoplasm, paroxysmal nocturnal hemoglobinuria, and heparin-induced thrombocytopenia. Usually, thrombosis testing is considered generally at young age. Patient who presented with thrombosis at young age, patient who has a recurrent VTE, unusual site, and patient with family history of VTE. And now we see a broader indication, not mainly indication, but a broader usage of or referral for thrombophilia testing for patient who has arterial thrombosis, and also in patient who had or pregnant ladies with recurrent complication. There are certain reasons why doctors or why thrombophilia are tested. One, to decide about preventative measures, such as in prophylactic scenarios, such as in a patient who seek to take oral contraceptive, or in high-risk situation, especially minor surgeries, pregnancies, and even during long-distance travel. Also, to have an explanation of the disease. Sometimes patient is requested to know, especially if they are young and they have family history, they want to know what type of thrombophilia they have. Sometimes physician thinks that it can show her or her skills as well. So there are 3 populations where thrombophilia testing can be useful: patient with VTE, relative, this one to prevent recurrent VTE. Also, in relative of patient with VTE to prevent the first VTE, those with the one who has a family history of VTE and in like during pregnancy or OCP usage. The third is the woman with pregnancy complication and to prevent recurrent pregnancy complication. Through this presentation, I will focus on the first 2. As the third one, still there is ongoing randomized trial, the ALIVE-2 trial, to see whether low molecular weight heparin can influence the outcome of patient with pregnancy complication. The prevalence of thrombophilia, the strong thrombophilia, the antithrombin deficiency of protein S and protein C are very rare compared to the more prevalent factor V Leiden and prothrombin gene mutation. And here it is important to know that those patients have a high risk of first episode of VTE. But if you notice that the risk of recurrence is not that high, it doesn't warrant the decision of to give or to continue anticoagulation after the first or the primary treatment, which is the 3 to 6 months. So this is the first home message of this presentation, is that the presence of inherited thrombophilia doesn't influence the recurrence or the duration of anticoagulation. There is no actually association from previous data with arterial thrombosis or pregnancy complication. What we do usually when we decide about the duration of anticoagulation is to decide whether the first or the episode was what was the setting during when the thrombosis or the clot happened. Is it due to provoked, which is the most common provoking risk factor, either major or minor, such as surgery, pregnancy, hormonal therapy, hospitalization, or the use of OCP, or persistent risk factor, which is the most common, cancer, and inflammatory bowel disease or connective tissue disease, and antiphospholipid antibodies. So this is considered as a provoked VTE. And then about 50% are unprovoked, where we can find thrombophilia and inherited thrombophilia in that category. So this is the scheme of how thrombophilia or how thrombosis is been treated. So irrespective of the index event, whether it is provoked or unprovoked, patients should be treated for at least 3 to 6 months. And irrespective also of the choice of anticoagulation. Then comes the secondary prevention, and we decide about the duration of anticoagulation based on the risk factor of the patient, whether it is a persistent risk factor, whether it is unprovoked. And here comes also the acquired thrombophilia, which should be investigated as well if the presentation suggested or the clinical presentation suggested its presence. Here, inherited thrombophilia doesn't play actually a role in deciding whether to extend the duration of anticoagulation or not. And the ACCB guidelines stated that patients with a provoked VTE by surgery, the recommendation is by 3 months only. And also the ASH Choosing Widely campaign mentioned that there is no need to test thrombophilia in those settings. But if patient has a VTE related to pregnancy or hormonal therapy, or with a strong family history and major transient risk factor, then the thrombophilia testing are complex, and clinician need to seek a VTE expert advice. The ASH guidelines, the latest 2020 ASH guidelines regarding the management of VTE, recommend that patient or suggest patient to continue anticoagulation indefinitely for those who have unprovoked VTE or provoked by persistent risk factor. And this is the acquired thrombophilia, which is important in terms of if you find any clinical data or laboratory data suggestive of its presence. So we have to suspect like myeloproliferative neoplasm when there is unusual site, when there is an abnormal CBC, such as high hemoglobin, high platelet, and if there's any features in the blood film suggestive of their presence, such as leukoerythroplastic picture, then we have to test for myeloproliferative neoplasm with the most common mutations, the JAK2, MPL, and CALR. And this would change the management in terms of adding cytoreductive agent, phlebotomy, along with the anticoagulation. Also, paroxysmal nocturnal hemoglobinuria is suspected when we have unusual site thrombosis, arterial or arterial clots in young patient, or features suggestive of hemolysis should be investigated. Also, because the treatment will be different by adding eculizumab through with the anticoagulation. Heparin-induced thrombocytopenia, this is most commonly after exposure to heparin, where there is a drop in the platelet along with the thrombosis. So it is also an autoimmune disorder, can cause arterial and venous thrombosis due to the formation of immune complex that involve formation of clots and removal of platelet, which cause thrombocytopenia. This is a very important topic, the antiphospholipid antibodies, because it's also can cause venous, arterial, and pregnancy complication. We go by the Savaro criteria, which involves either venous or arterial thrombosis and pregnancy complication, along with the laboratory criteria that involve testing for lupus anticoagulant, anticardiolipin, beta-2 glycoprotein, and should be confirmed 12 weeks apart. So to summarize the first part of acute VTE, provoked by strong risk factor, there is no role for testing, but when there is any unprovoked VTE, then the role of testing should be determined whether to test for inherited or acquired. So antiphospholipid should be investigated in young female patient with features suggestive of lupus anticoagulant or antibody or lupus antibody syndrome. If patient comes with thrombosis in the setting of pregnancy or OCP, then we have to determine the role of testing. So maybe this will help in not in this acute setting, but to prevent family member by testing for the deficient thrombophilia, either protein S, protein C, or the others. For unusual site thrombosis, it's always important to consider acquired thrombophilia, the MPN, PNH, and lupus anticoagulant. So what I'll do in the first case is, because it is a provoked thrombosis, then there is no role for thrombophilia testing, and we'll give anticoagulation for 3 months. For the second one, which is unprovoked, a young lady with unprovoked VTE will receive 3 to 6 months, the initial phase of anticoagulation, then should be, then the risk, of course, the risk of bleeding should be assessed, but thrombophilia testing, I will do antiphospholipid antibodies, and I will consider inherited thrombophilia, as I just mentioned, to prevent, when any family members seek oral contraceptive or during pregnancy, it will be helpful to know what kind of thrombophilia she had at that time. In the third case, patient with unusual site thrombosis, having an high hemoglobin, which is suggestive of the presence of polycythemia, then the initial workup with CBC, blood film, and they will send for JAK2 mutation. Here we'll give indefinite anticoagulation, hydroxyurea, and venesection. The second part is the VTE during pregnancy, and the risk of thrombophilia or VTE with thrombophilia during pregnancy is increased mainly in the postpartum period. And the ASH guidelines, the 2008 guidelines, mentioned that irrespective of family history, patient with inherited thrombophilia should receive postpartum anticoagulation. But if patient has antithrombin deficiency with family history, then it should receive antepartum and postpartum thromboprophylaxis. For more strong thrombophilia or combined or homozygous factor V Leiden, then the ASH guidelines mention that antepartum and postpartum anticoagulation should be received. Also, the oral contraceptive, the usage of oral contraceptive increased the risk of thrombosis and with thrombophilia, and mainly with the strong thrombophilia. Also, factor V Leiden increased around 30 times, but because the risk is to begin with is very low, 0.02. For patient without thrombophilia using OCP, the risk increased to 0.5 And so this is the 2010 guideline, PCSH guidelines, that patient with first of all, patient with family history and usage of OCP or hormonal therapy, they have a twofold increase the risk of thrombosis, irrespective of the thrombophilia. So if we don't know the one who has a thrombosis, like the mother or the first degree relative have been not tested, then if test for the thrombophilia testing is not recommended, but we'll consider alternative method of contraception and the transdermal hormonal therapy. If that patient was tested and found to be negative, then if testing for this patient wouldn't give it will give uncertain estimate of the risk. So it is not recommended because it might mislead. The third, and if that patient was tested and there is a known thrombophilia, it is feasible just to test for that known thrombophilia, just to make sure that the patient has the same thrombophilia or the same inherited thrombophilia. But again, will suggest giving alternative contraceptive. So what I will do in the fourth patient, I would consider alternative contraceptive method such as Mirena IUD and thrombophilia testing in that patient with the pregnant lady to decide about antepartum prophylaxis. My last slide about if we decide to test, when to test. So avoid testing in acute VTE. That would lead to low antithrombin protein C and protein S. And it should be also after completion of the first phase, the 3 to 6 months, and avoid testing while on anticoagulation. With warfarin, stop at least 2 weeks. With DOAC, 2 to 3 days. And because this is also because we'll give low antithrombin protein C and protein S, and lupus anticoagulant might come false positive. The gene mutation, beta-2 glycoprotein, or the ELISA test for antibody, lupus anticoagulant, and JAK2 mutation, flow cytometry can be done anytime during thrombosis. And my last slide, and the important point is that to identify goals in order to aid decision on making regarding the future VTE prophylaxis, to guide testing of family members, especially regarding the risk associated with OCP, pregnancy, or pregnancy in family members, and to determine the cause, especially for severe VTE, fatal VTE in a family members, or VTE at unusual location. It is important to know that test result alone should not be used for decision-making regarding duration of anticoagulant therapy. Thank you so much.
Okay, thank you, Dr. Al-Badr, for a great presentation. The second speaker is Dr. Sarah Suwar Al-Dahab. Dr. Sarah is a board-certified internist, hematologist, and medical oncologist. She completed her internal medicine training at University of Maryland Medical Center, followed by a fellowship at MedStar Georgetown Washington Hospital Center. Dr. Suwar Al-Dahab also attained Master in Public Health and Epidemiology in the University of Miami, followed by a year of research in Johns Hopkins School of Medicine. And she's working on bleeding diathesis in the cirrhotic patients under the Department of Hematology. Dr. Suwar Al-Dahab is an active member in many local and international societies. Dr. Suwar Al-Dahab is going to make the case for thrombophilia testing is unnecessary. Dr. Suwar Al-Dahab, the floor is yours.
Assalamu alaikum, everyone. Thank you for having me here today. And I want to thank my opponent. You made some very valid points. I think we agree on many things, but I'm going to try to prove you wrong today because that's what a debate is all about. I'm going to be talking اليوم about how thrombophilia testing is unnecessary. But I want to start by saying that there are no absolutes in medicine. So every rule has an exception and one size does not fit all. And patients don't actually read textbooks, and that's what they've been teaching us. So my debate here today is not to prove that no one benefits from thrombophilia testing ever. It's also not meant to argue against the increased risk of initial thrombosis or VTEs in patients with thrombophilias, which is something that's been studied and documented and we all agree on, I believe. But it's meant to argue that most of the thrombophilia testing that we actually tend to do, and it's performed whether by PCPs or other specialists, or sometimes even some hematologists, is unnecessary. So I think a more accurate title for my talk would be thrombophilia testing is almost always unnecessary. Let me start by, this is the outline of my talk. Let's start by what do the guidelines say? I think we all have to follow evidence-based medicine. So this is the ASH Choosing Wisely guidelines that you had mentioned. And they basically state that you do not test for thrombophilia in adult patients with a venous thromboembolism occurring in the setting of a major transient risk factor such as surgery or prolonged trauma. This is a draft of ASH recommendations for thrombophilia testing. They were closed for comments in the summer of 2021, but we're waiting on the final version of the draft. I just want to comment on, this is available online for us to review, but it's not something that has been validated or agreed upon yet. So you can use it for information, but it should not be used for citing or use in research yet. This is the NICE guidelines, the National Institute for Health and Care Excellence guidelines for thrombophilia testing. And this was published in 2020. And it basically says that you should not be offering testing for hereditary thrombophilia to people who are going to remain on anticoagulation. You should not be offering it to people who had a provoked DVT or PE. You can consider testing for antiphospholipid antibodies in patients with an unprovoked DVT or PE if it's going to be changing your management between stopping and continuing anticoagulation. You can also consider testing for inherited thrombophilias in patients who had an unprovoked DVT or PE, who have a first-degree relative who had a DVT and PE, and you're also debating stopping or continuing anticoagulation. And other than that, you should not offer routine thrombophilia testing in first-degree relatives if the relative had a DVT or PE in that situation. This here is the British Society for Hematology clinical guidelines for testing for heritable thrombophilia that you had went through also, and it's the 2010 guidelines. I just want you to look at the testing recommendation, or when is testing recommended in these cases. You'll note that most of the level of evidence in these patients is actually a level 2 or below, except for testing asymptomatic relatives with a high risk of thrombophilia in select thrombosis-prone families. So they're talking about these families that come to you and you have multiple cousins or multiple siblings with thrombophilia. But this is the table of all the situations where thrombophilia testing is actually not recommended in patients. And it covers everything from unprovoked DVTs to upper limb thrombosis to cancers, to central line associated thrombosis to children with strokes. So it's a much more extensive list, and the level of evidence in this is much higher. You'll notice that most of them are a level of evidence of 1A or 1B or C. There's nothing that's 1A because again, there are no absolutes in this topic at all. Let's talk now about, does it actually change our management? Because if it does, then by all means, let's all get tested or get patients tested. So why does it not change our management in the acute phase of a VTE? Well, first of all, full intensity anticoagulation is needed independent of the thrombophilia testing in the initial phase. And this again goes with the ASH guidelines, the 2020 guidelines, that says that patients with a DVT or PE provoked by a transient risk factor, whether it's major like surgery or something very minor like a plane trip, the panel suggests a short duration of anticoagulation of 3 to 6 months. So in the acute setting, it really doesn't change anything. The ASH Choosing Wisely recommendations state that thrombophilia increases your risk of the first unprovoked VTE. A VTE in the setting of a clear major risk factor does not warrant testing in these patients. there's a questionable validity of repeated, and it results in repeated testing and increased costs. Things like lupus anticoagulant, protein C, protein S, antithrombin can be altered in the presence of an acute thrombus or being on anticoagulation. Sometimes inflammatory and pregnancy conditions can also alter your testing. So there's really no need, and then you end up needing to repeat testing in these patients, and that costs money and time and results in anxiety for these patients. And finally, there are no clinical trial evidence of the benefit of this. There was a study that tried to look at the benefit of thrombophilia testing after the first VTE, and that was called the Nostradamus study. But this study was actually terminated early. It was done in the Netherlands. It was terminated early due to low enrollment and lack of funding in these patients. All right. Does thrombophilia testing then change management in the chronic setting or the long-term setting? Well, there's actually no difference in VTE recurrence in these patients. There's a study by Copens et al. That was published in 2008. And in this study, they looked at 197 patients with VTE recurrence, and they compared them to controls, which were 324 patients without VTE recurrence. And they calculated the odds ratio for recurrent thrombosis in the patients that were tested and the non-tested patients for thrombophilia. They found that, first of all, thrombophilia testing was done in about 35% of patients that were cases which had recurrent thrombosis, and 30% of controls which did not even have recurrent thrombosis. So the rate of testing did not differ that much in these patients. But the odds ratio for recurrence was 1.2, even after you corrected for things like age, sex, family history, geographic location, presence of clinical risk factors, and whatnot. So there is no difference of recurrence. This is a long slide. This is my busiest slide probably, but the high-risk patients, you'll need to continue them on anticoagulation regardless of their thrombophilia status. So ASH guidelines of 2020 are saying basically, if you have if you complete primary treatment for a DVT and PE that was provoked by something chronic, a chronic persistent risk factor, think of your patients with uncontrolled lupus, Crohn's disease, all these patients, then ASH recommends that you continue indefinite anticoagulation. Similarly, if you complete primary treatment for an unprovoked DVT or PE, ASH also suggests that you continue these patients on indefinite anticoagulation. So if these patients are going to remain on anticoagulation, why would you really test them, right? I will add to that if you have a patient that you're so worried about that you would not like to stop anticoagulation long enough to test them, then your decision for continuing anticoagulation has already been made, and it really doesn't change anything in terms of knowing what they have. The third point I want to make is that the high-risk setting requires prophylaxis in these patients, regardless of their thrombophilia status. So both patients with a VTE and an inherited thrombophilia and patients with a VTE but without an inherited thrombophilia are going to require prophylaxis in subsequent settings of surgery or hospital admission or acute illness. And the last thing is the ASH choosing wisely recommendations again, where they say that when a VTE occurs in the setting of pregnancy or hormonal therapy, or when there's a strong family history plus a major transient risk factor, thrombophilia testing is very complex, and these patients and clinicians are advised to seek expert guidance from thrombophilia or VTE experts. So it's a very difficult decision that needs to be individualized to every patient. All right, let's talk about whether it is necessary and is it reliable, which is a very strong thing that we have to look into. Most coagulation experts are going to be able to identify patients with an inherited thrombophilia based on the patient's personal and family history of VTE alone. And here I have a table that I'm going to have to go forward and then come back again. Let's try. All right. This is the table we're looking at. These are the clinical characteristics suggestive of an inherited thrombophilia in a patient with a VTE. And you'll see that thrombophilia at a young age, especially something associated with a very minor risk factor or an unprovoked VTE, having a strong family history of VTE and first degree family members especially affected by it, recurrent VTE events, especially at a young age. These things include antiphospholipid syndrome and VTEs at unusual sites, such as splanchnic or cerebral vein thrombosis. Now I'm going to go back. Sorry for the confusion that we're having here. All right, so we looked at this table now. Let's look at the current tests that we have for inherited thrombophilias, right? There's insufficient we don't have all the tests we need to identify all inherited thrombophilias. We've all seen patients that clearly have something that's genetic, but you test for all the common mutations and you cannot pinpoint or put your hand on a specific problem. There are some tests that are associated with strong independent heritable risks for development of VTE. Now I have to go forward again. I apologize. It was supposed to be hyperlinked. All right. So this is here. These are all your common thrombophilias that we tend to see in our patients, including your heterozygous and your homozygous states. We have the prevalence of them. And as you can see, things like protein C, protein S, and antithrombin deficiency are very rare, although they're the strongest inheritable thrombophilias that we carry. But then you'll see that the relative risk of initial thrombosis actually differs in these patients. And you'll note that the rare diseases actually have a higher relative risk of initial VTE, obviously. But the most common ones that we tend to test for carry a very small risk of initial thrombosis. The thing I want to point your attention to is that the relative risk of recurrent thrombosis is not that bad in all these patients, despite their risk of initial VTE. And then you'll see in the fourth column there, the relative risk of initial VTE in OCP use. And you'll notice that things like antithrombin deficiency has about up to 100, a relative risk of up to 115. So these patients, yes, we do worry about when you're using OCPs. But generally, the risk of recurrence is not that high afterwards. We'll go back again. All right, so some tests have not been conclusively studied, and we have not been able to prove that they actually cause thrombophilia, and these require further validation. These include things like your factor VIII, your PI1, promethylation, or polymorphisms that we have. Things like the MTHFR polymorphisms are actually not associated with any risk of VTE or recurrence, and I would be very happy if they take them off of any thrombophilia pattern. There's also little to no contribution of inherited thrombophilias in the development of arterial thrombosis. So if you have a patient with an arterial thrombus, don't test them for most of these thrombophilias. You could test them for antiphospholipid, you can test them for MPNs, but the inherited thrombophilias don't carry any weight. Antiphospholipid antibodies are an acquired cause of arterial and venous thrombosis. And to diagnose it, you have to have strict clinical and laboratory criteria, the Sapporo criteria. But the lab tests are usually affected by the acuity of the thrombus and the anticoagulation. All right, does it reduce risk of recurrence then? Well, the 5-year absolute risk of recurrence approaches 30% unless you extend the duration of anticoagulation in these patients. Healthcare providers, though, often overestimate these risks. If you ask every healthcare provider in this room, each of you will give a different perceived risk based on your own experiences and the patients you've seen. The risk prediction models that we do use, things like the Vienna score, the HER2 score for recurrence of VTEs, actually does not include inherited thrombophilias. And some models excluded these patients completely from their tests or for trials. And if a patient is going to remain on indefinite anticoagulation based on the known recurrence risk of 30% above, then thrombophilia testing is not going to add anything additional to these patients. Finally, there were multiple studies that were done that were unable to demonstrate a significant difference in rates of recurrent VTE in patients who were tested for thrombophilia versus those who were not. And this gives you the risks in numbers. You'll see that your prevalence of any thrombophilia is about 38% if you have various unprovoking factors or minor provoking factors. Your risk of an inherited thrombophilia in something like a cerebral vein thrombus or a splanchnic vein thrombus is about more than 40%. And your risk of recurrence varies anywhere from 10 per thousand up to 100 per thousand. But your relative risk of recurrence does not change across the board. It's 1.65 in these patients. So, and your major risk of bleeding, and this is talking about patients who have a mild risk of bleeding. We're not talking about a cirrhotic patient that has esophageal varices and keeps bleeding on you. But your risk of recurrence doesn't change that much in this table, as you can see. All right. Finally, does it reduce healthcare associated costs? We have to be very conscientious of how much things cost, whether it's for our patients or for the social healthcare system that we're part of. And in this study by God et al., basically, it was a single center retrospective study that had 266 patients in it. They had They tried to determine the pattern of thrombophilia in patients with VTE. They wanted to also study the impact of thrombophilia testing on the decision-making of patients, and they wanted to determine the direct cost of thrombophilia testing. They found that almost 27% of tests were positive for thrombophilia. So about 30, let's say 30%. 37% of patients had thrombophilia testing while they had a provoked VTE, which is a really high number for this. About 12% or 11.6% of all ordered tests were uninterpretable because of being confounded by the acute clot or use of anticoagulation. So this is a wasted test. Management was impacted only 17% of the time. So out of all the testing you've done, you've changed your management about 17% of the time in these patients. The costs of thrombophilia testing, these costs I'm going to show you do not account for complications, downstream related issues with extended anticoagulation cost the patients, anxiety associated with a false positive, or the complications occurring with bleeding in these patients. So it costs about $2,364 per patient to test them for thrombophilia. It costs more than $12,000 to diagnose one positive thrombophilia, and it costs close to $20,000 to change per one patient management changed. So, yeah. All right, let's look at oral contraceptive use. The screening for all thrombophilia in women before prescribing oral contraceptive use is going to cost you about $270,000 to prevent one additional case of venous thrombosis. In factor V Leiden, it's going to cost you close to $18,000 in management costs when you compare them to no screening to prevent one additional vascular event. And it's going to cost, this cost was reduced to $10,000 if you screened only those with family members or personal history of venous thromboembolism. This is a lot of money that can be put to use in our patient population and in our hospital. So why am I trying to convince you not to obtain thrombophilia testing, or at least leave it until it will change your management? It's because there's limited data on the benefits. The duration of anticoagulation actually depends on your nature of thrombus, not on the thrombophilia testing that's present. There's lack of benefit if it is provoked. There's no benefit of testing if you do it in a provoked DVT. There's no reduction in recurrence risk after an initial VTE. The prophylaxis in patients is needed with a positive family history. So a family history alone, a good clinical history with a patient, is going to offer you prophylactic recommendations. And finally, it's a high cost issue with very low yield. It's time consuming, it's very expensive, and it rarely changes management. And thank you very much.
So I guess we will start the Q&A session, and we will start to take questions. Please raise, we have a hand raised already. So please, can you hand the microphone over there?
Hello. Do we need the speakers to come up on the stage or no need?
Hmm?
Do we need them to come up on stage, the speakers, or I will just have to hand it?
Please, yeah, we would like
Yeah, and we could
speakers to
ask
come
this
stage.
gentleman to
Do
bring
we
us
have
at
enough
least
chairs?
chairs
No?
for us. Can you help us bring some chairs in there
Can you bring
for
chairs,
the speakers to sit on? Yeah, thank
Yeah.
you.
Can you bring chairs?
At least just add 2 chairs. Yeah. Doctor, could you proceed to the one more chair? The other microphone.
Thank you very much for these very interesting talks. And I think a lot of people are thrilled to ask the first question. And we have, excuse me, we have someone here to ask question.
Yeah.
First.
Okay.
Can you have
Hold on.
another microphone beside? Or maybe we'll just ask the speaker to come to the podium when the question is for him. Yeah. Okay. The microphone works? Okay.
Good morning. I am Dr. Tariq El-Gimizi from King Abdulaziz University Hospital. My question to Prof. Ammar. I'd like to thank you first for your excellent presentation about the plasma transfusion update. What do you think about the challenges of starting a project for plasma fractionation in our developing countries? It is still a dream. Can we reach it?
Very big strategic question, but we are our population is almost 30 million plus, and experience from other countries like Canada, or even countries of large population like Brazil, or some countries in South America. This is on one side. On one side, this project started, then interrupted, and didn't continue. And the feasible option was to ship all their plasma to another fractionation site to process it all. So Saudi plasma goes into one fractionation site and bring it to us as a product. This is one option. The limitation for this is cost effectiveness. The minimum you need is maybe 10,000 to have one lot is a 10,000 liter per lot, and this is a lot of plasma. This is almost 50,000 donations per year. And this is not easy. You have to establish a very big infrastructure of plasma collection sites with payment also, as everybody else done. This is in one side, some of the experiences, it didn't succeed very well. Okay, but this is my my gut belief. It's that we don't have to start early with the plasma fractionation. It's ideal. Maybe it is good to start with the development experience, establishing the infrastructure of plasma collection, and then outsource the manufacturing, in the process of fractionation and development. And then we get it back as a fractionated product, which are very expensive. And by that, we will save, according to the most of the cost goes into the plasma itself, according to them, according to the fractionation companies and experts. So almost 60% of the cost is in the plasma itself, which is paid plasma. If we can save on that for some time, until we develop experience and know what are our needs, and study it very well, and maybe collaborate with other countries, neighboring countries, that includes the Gulf countries, Egypt, for example. I know Egypt is doing that now in collaboration with another company. I think maybe it is better for us to do this in the first phase until we mature our curve, learning curve, and expertise goes up. Then maybe we can go to the next level of fractionation. Maybe early in the initial phase, maybe you can do solvent detergent, where we convert all our plasma into safe plasma, plus sending it to the fractionation, some of it. This is I think this is maybe better.
Ammar, I think we can go to the second question. I have a hand here raised.
Thank you all for the excellent presentation. My question to Dr. Sarah, how would you stratify patients to decide about the duration of anticoagulation after the first 3 to 6 months in clearly unprovoked patient? Would you do the prediction model like HERD2 or Vienna? And if you do, and for example, it comes low, knowing the fact that they excluded thrombophilia patient from these studies, would you do thrombophilia in this patient?
So this is working. All right. In terms of how I personally decide how to extend anticoagulation is I bring the patient in at 3 months, and then I bring them again at 6 months. Each of these time points, I decide if I want to stop at that point or extend it a little bit further. And a lot of things that come into play. Let's say I have a patient with a DVT or a PE. Are they functional? Are they back to baseline or close to baseline? Do they remain short of breath? Do they continue to have pleuritic chest pain? If they have any of these things, then I continue anticoagulation for a little bit more. At that 3-month time point, a lot of times I may involve getting a D-dimer level and have that help my management, plus or minus getting Dopplers to make sure that their DVT has resolved or is it chronic or still there. If the initial event was a massive or submassive PE or a DVT that is large and extensive, especially if it starts involving something as high as the iliac vessels, then that automatically in my mind buys them 6 months of anticoagulation. Once we get to the end of the initial anticoagulation phase, then I really have to sit with the patient and see how they're doing at that time point. And I think it has to be a joint decision-making between the patient and I, right? Some patients don't mind taking anticoagulation, knowing the risk factors. And in those patients, and they're more worried about the DVT than they are about the bleeding risk. And if you remember from the table, their DVT risk or their risk of death from DVTs is usually higher than bleeding. So if they feel okay with remaining on anticoagulation, we can do that. If some people don't like taking pills, they don't think that's something they can maintain or continue to do. In these patients, as long as I explain the risks and benefits for them between the recurrence of DVTs and not, you can take them off of anticoagulation, but give them a very good baseline of what should bring them back and when they should be started on prophylactic anticoagulation, whether they come to us in our institution or go to another institution. So I think it's a patient, I have to kind of decide on it patient by patient, honestly. But prediction models are very helpful and sometimes I use them. And I think if you use the prediction models, most of them are based on your clinical sense and gestalt in addition to specific numbers like D-dimers and Dopplers.
Thank you, doctors.
Do we have, we have time for a third question, but it has to be short with a short answer. We have 3 minutes only. Any more questions? Yep, question over there. I repeat, short question, short answer, please.
Assalamu alaikum. Assalamu alaikum. Thank you for both speaker, Dr. Muhammad and Dr. Sarah. Three quick questions. The first question, if you have a 14 years old male, so 14 and male with unprovoked DVT, are you gonna testing him for thrombophilia or not? Focusing in male and age. The second question, if you have arterial thrombosis for a young patient, are you gonna testing for protein C and S specifically for age less than 55? And the last question, if the patient requests testing for thrombophilia and he's willing to pay for that, are you gonna proceed with that or not?
I'll give you my quick answers. I think the 14-year-old with an unprovoked DVT, if it's truly unprovoked in that patient, I'll continue anticoagulation for 3 months. And then I think I'll sit at that point and maybe get a good family history and decide whether to test them for something or not. If the family history is completely negative, and I don't have any risk or suspicion for an acquired thrombosis, I may not test them for an acquired thrombophilia and keep them on prophylactic anticoagulation in high-risk situations. Your second patient was what was it?
Arterial thrombosis, young, and are you gonna testing for protein CS specifically if the age less than 55? As we know, the risk of is like 4.5-fold. Antithrombin, no. Age more than 55 is not.
Arterial thrombosis, no. I would test them for PNH. I would test them for MPNs because it can happen. And you would test them for antiphospholipid, but probably not protein C and protein S. What's your third one?
If the patient requested and he's willing to pay the cost.
If it buys the patient a peace of mind, then yes, I would do it, because if he doesn't get it with me with good counseling, he's going to get it with someone else with poor counseling. But I have to also explain that a negative test does not mean that they don't have an inherited thrombophilia.
Thank you.
Thank you, Dr. Ail. I think you asked the 3 hardest questions. I will start from the third one. Basically, if the patient asks and that will make him stress relief, then I would do it by explaining or after investigating thoroughly the acquired thrombophilia, especially in young age, as we mentioned, PNH, MPN, and antiphospholipid antibodies. That wouldn't change anything in the acute management, at least up to 6 months. He's a male, the risk of recurrence might be higher. So we'll continue anticoagulation after counseling the patient, taking in mind that he's young, he might play sport, he might, so he needs a close follow-up in terms of explanation regarding the choice of anticoagulation, especially whether if now we are in the direct oral anticoagulant, so whether once or twice a day, the timing of taking the drug. So that needs a more educational method. The other question regarding, that's might answer the first question as well. Arterial thrombosis, I have to rule out arterial causes, like do thorough investigation, echo, I mean, to rule out atrial fibrillation, to rule out patent foramen. So to rule out any arterial causes, I wouldn't do thrombophilia specifically for arterial causes. I have to rule out the acquired thrombophilia as well.
Thank you very much for the audience and for the great speakers. With this, we conclude the session. Thank you very much.
Hello, there will be 15 minutes coffee break, and we're gonna get back after that for the next session. Thank you.
we can start. Assalamu alaikum. Good morning, everybody. My name is Ghalib Al-Yamani, consultant hematopathology, Prince Sultan Military Medical City, Riyadh. I am the moderator with my colleague, Dr. Ammar Al-Sughayr, in this meeting. It is my pleasure to start the second session. We have 3 speakers in this session: Dr. Lubna, Dr. Gary, Dr. Saeed Al-Shiban. We will start by first speaker, Dr. Lubna. Dr. Ammar, he will. Okay, so Dr. Lubna is a consultant hematopathology. He graduated with bachelor degree of health science and MD degree from Sultan Qaboos University Hospital, Oman. She carried on his fellowship in hematology, FRCPA from Sydney, Australia. He currently is a consultant hematopathology, Department of Pathology and Laboratory Medicine in Sultan Qaboos Comprehensive Institute. He will talk today about flow cytometry indication and the application in different aspects of in hematological, and will focus in hematology and hematology oncology and the other also benign blood disorder. Dr. Lubna.
Assalamu alaikum wa rahmatullah. Thank you for the chairman for introducing me. It's my pleasure to stand here today and give this talk in this very organized conference and in this wonderful city in the kingdom. This one? No. Must be. So, how do you have a slide? Next. Okay. Okay. So basically, as you know, the flow cytometry is a measurement of cells that's passing through a flowing streams, and we pass a beam of light that are directed to these cells, and in the end, there is a detectors. Sorry, we don't have a pointer, but there is a detectors that will detect the forward and side scatter characteristics of the cells, and the fluorescence that is emitted from the stem cells that already we are attached to these cells. And with having more fluorescent label antibodies, we are able to categorize the cells in a graph, and we can detect cells that expressing either antibodies A or B, or neither of them or both of them. So in my presentation, I will just highlight the application of the flow cytometry in hematological disorders, and I elaborate on validation process and the best practice in flow cytometry, and I give you some pitfalls about the test and how to suggest and some suggestion for approach and guidance of the diagnosis with the new application and recent development in flow cytometry in hematology. Basically, the flow cytometry was available commercially more than 14 years ago, And the start was with measuring only 1 to 2 cells, cellular parameters. Today, we have routinely able to analyze thousands of single cells within seconds and measure up to more than 20 fluorescent parameters simultaneously. With the improvement of monoclonal antibodies, fluorescence, and laser technology in the flow cytometry, it offers new avenues of assessing cellular functionality through examination of intracellular compartment. So even from the forward and side scatter, you can see that we can get the characteristics of cells like neutrophils, monocytes, lymphocytes, and we can also allocate abnormal cells like blasts. With addition of the addition of fluorescence signals like the antibodies of CD45, we can categorize these cells more better and identify them better. So the flow cytometry will provide us a prospective measurement for detecting the origin of the disease of the cells and the diagnosis, classification, staging, plus the treatment options, especially for those with specific antibodies and targeting cells, and also after treatment follow-up. This is the application of flow cytometry in hematology that recently has been already has been implemented and already validated. Mainly the flow cytometry is widely used in leukemia and leukemia identification and lymphoma characteristics, phenotypic characteristics. And also it's play a major role in identification of prognostically important subgroups and recognition of those with specific antigen associated with therapeutic values. Not only that, we can use the flow cytometry in CD34 enumeration for stem cell transplant, and it is also useful for fetal-maternal hemorrhage quantification. In blood bank, it also has an implementation for assessment of leukocyte contamination and immunohematology. For inherited disorder, we have already validated this for PNH and for the hereditary spherocytosis and related defects and inherited platelet disorder. However, to get up to this decision or to identify these antibodies and to get the proper immunophenotyping from this flow cytometry, the process is not that much easy. It goes through a very sophisticated process and procedure has to be held by expert cytometrists and pathologists in order to get the accurate result and be precise in the diagnosis and quantification of the immunophenotyping. And this process take a really long time or a good effort. This is a schematic diagram. I made it based on the European Leukemic Net and International Council of Standardization of Hematology and International Clinical Cytometry Society, where the flow cytometry process that or test best practice is based on the pre-analytical, analytical, and data interpretation. And the pre-analytical and analytical is the major one that we have to establish it very well in our lab prior to give the data interpretation. Anything in this side will just lead to wrong interpretation or a problem in our interpretation. So the pre-analytical starts just from simply like any test, from the sample preparation or sample collection, what the preservative that we are using, the anticoagulants or the culture media, and what is the cell count in the specimen and the viability of the cells. And then for analytical, before we ask for the specimen, we have to have a method development, method validation, and we have to make sure that this is already set up in our lab before collecting the sample. With the data interpretation, based on these prior things, we'll go for the checking the event acquisition and the disease pattern of the assessment, together with any clinical history and ancillary tests like morphology, molecular, and other things. So starting with the specimen preparation, the flow cytometry able to assess a sample from blood, peripheral blood, bone marrow, fresh tissue, fine needle aspirate effusions, body fluids like CSF and pleural effusions, And in general, it's required fresh and fixed samples. However, as all the specimen, all the specimen that comes to the flow cytometry has to be properly labeled with the patient identifications and has to be taken as in consideration like it's a biohazard specimen and treated as a regular or local guidelines. Okay, this is the summary for the preferred sample requirements for the flow cytometry from each specimen type. It depends on how you long take after collection going to process the sample. So preferable container for peripheral blood usually is the sodium heparin. It gives you more time stability for the cells up to 72 hours. With EDTA, it just takes 2 to 48 hours. Also, you can use ACD. For bone marrow aspiration, it's preferable, the sodium heparin. Also, EDTA is acceptable. For bone marrow biopsy or the other tissues biopsies, it's preferable to bring it in RPMI tissue culture medium. And for CSF and the body fluid, usually we are preferring sterile container, universal container. Okay, so usually there is no anticoagulants for a tissue. We use RPMI. Okay, very important part, and that is most of the hospital is missing it particularly in the flow cytometry, that we need the requisition form. This requisition form not only having the patient identification and the age and the diagnosis, it's also containing any recent treatment for patients, and the time and date of collection of the sample, and the source of specimen, because this is really, this is very important information. Usually in a good setup of the hospitals, usually we have a communication with the physician who requested, and we ask about medication and the diagnosis. This is a help in interpreting the data that we acquired in the flow cytometry more properly. And it's very important to standardize it or have it in the system available for the physician when he's requesting flow cytometry. Based on the local guidelines of specimen processed in your hospital, the processing of the sample in flow cytometry will take place. Note that all the precious sample like CSF, bone marrow samples, samples from tumors with high proliferative index and apoptotic rates like Burkitt lymphoma has to be processed as soon as possible. And the bone marrow sample evaluated for multiple myeloma also has to be processed as soon as possible. This has to be regulated in every laboratory in the flow cytometry section. Another important point before assessing the sample, we used to do the cell count to find out how much the cell count in the specimen, so that we are estimating how much the antibodies that we're going to add it in the specimen and also to see the number of the cells and if it is adequate to proceed in the test. For instance, like CSF with low cells less than 1, usually we don't proceed to go flow cytometry. It's unnecessarily waste of the test. Okay, and this is a very important part also. After we assess the count, we should assess the viability of the cells. By using this, the anticoagulant and preservative media for tissue, we can preserve the cells for longer. However, we get sometimes samples with non-viable cells, and this can be assessed only from the forward and side scatters as seen in the left side diagram. And with addition of viability dye, like the amine reactive fluorescent dye, it gives us more accurate assessment of the quality of the specimen and the viability of the test. Also, before we are starting the assessment of the data of the flow cytometry, we should look at the morphology of the specimen. either from the slide prepared by from the peripheral blood or bone marrow, or we can do cytospin for the fluid and the CSF samples. Now for the analytical part, which is, it's really purely lab. However, it's very important to have it. And this is where we come in action in the lab. I based my section, this section on the best practice from the International Council of Standardization of Hematology and International Clinical Cytometry Society that has been published in 2013. And before you start all that, you have to have, your laboratory infrastructure and the instrumentation that you are using, instrument setup, maintenance and performance, any critical reagents, raw data and data acquisition, and the analytical methods. The analytical methods goes with these several steps, started from method development, specificity, getting strategies, getting controls, and use of QC. And with the validation steps that include precision, sensitivity, robustness, accuracy, stability, long and short-term frozen stability, post-sample processing stability, run acceptance criteria method validation, and bioanalytical report. All these things has to be proceeded your analysis. It's already set up for each imaging, for each antibodies tested and each panels that we are testing. So this has to take a place in the flow cytometry laboratory. And you can see the list of the method development that I mentioned, some of them there, including also fixation and gating strategies and standardization of your control. This is again another minimum requirement that has been requested requested to be available for your flow cytometry before assessing your sample. Some tips for the flow cytometrist and the pathologist to be considered when you are assessing or you do your analytical standardization. There should be an optimization of voltage setting, titrate each antibodies for optimal performance in the panels, and carefully consider the pairing of the dyes with the targets and minimizing spillover spreading. And we required in 8 to 10 colors. Staining requires computer algorithm to keep track of multiple areas of signals overlapping. The compensation between the two channels is set at 72%. And the protection of antibodies from direct light can help in removing any false positive tests while you are analyzing. Sample with PAUSI cells like CSF or those for MRD should be assessed, as I said, immediately after collection, and also make sure that your instrument is clean and there is no carryover. You did a test with high positive finding, and then it's carry over to your test of the patient with the PAUSI cells or less count like CSF sample. So in order to achieve accurate and consistent data interpretation, a predefined protocol with the antibody combination pre-selected to simplify analysis is essential. We know that there is we are based on our diagnosis of especially leukemia and lymphoma in the WHO criteria, and it gives us very broad information about which category that we can classify the disease. However, we know that there is the recognition of the hematopoietic neoplasia by flow cytometry. We know it because they are different from immunophenotype from normal counterparts. Also, we know that the immunophenotype associated with normal hematopoiesis is not static and is characterized by shift in antigen expression that occur during maturation and with various states of activation. The patterns of antigen expression associated with normal hematopoietic cells may also vary depending on the specimen type. We know that leukemic cells may show early or minimum differentiation, and some diagnostic entities can easily be confused with other because of their atypical immunophenotype, like what we can see in the cases of immature blastic plasmacytodendritic cell neoplasm and early T cell precursor leukemia. We can easily misdiagnose it with AML M0. But with the help with the adding more antibodies and assessing more fluorescence in the flow cytometry, we can nowadays clearly separate these entities. Okay, so there was a consensus recommendation and guidelines has been recently generated by several expert groups, but none of these guidelines has attempted to standardize the whole flow cytometry analysis. The Euroflow consortium developed a fully standardized approach for immunophenotyping in hemato-oncology, and it starts from the basic startup of the flow cytometry till the data interpretation. This has been published in 2012, and after that, in 2015, the Euroflow quality assessment program was developed. So there is a standardized antibody panel established by the European Leukemia Net and the Euroflow, and basically now most of the laboratories is using this, it is just that for each category of disease, you have a screening tube that you start with it and you proceed with other subsequently other markers. So for the suspected case of leukemia, acute leukemia, you start with the acute leukemia orientation tube, which is basically cytoplasmic CD3, CD45, cytoplasmic MPO, cytoplasmic CD79A, CD34, CD19, and CD7, and surface CD3. So it takes antibodies from each type, from each lineage of acute leukemia, and plus the premature cells, and show us which lineage we are dealing with. So if it was T cells or B cell leukemia, or it is AML from the allot, we find it. We proceed with the other sorry. How to go back? So proceed with the other tubes for specific, for example, B, acute B lymphoblastic, or T lymphoblastic, or we go with the, if it is AML, we go with the more tubes of AML. Okay, if it's lymphoma, we go with the lymphoma screen tube. And if it is multiple myeloma, we go with the plasma cell screening tube, and we proceed according to our finding. If it's become clonal, we go with the plasma cell disorder tubes. And if it is, and there is also for small sample, there is for small sample, there is a special tube to assess the categories of these cells. So basically, the Euroflow gave us an aid in our clear standardization from where to start with the antibodies panels and how to go further without waste of the antibodies, without waste of the time to find out. But again, we need okay. So I don't know why I keep closing my. Go back again. Sorry. So I just will give you a case that has been come across in the National Guard in Riyadh. After the patient is diagnosed with multiple myeloma, and he has circulating plasma cells. So okay, okay. So he has circulating plasma cells. With doing the flow cytometry, we find this patient have CD138, but is lacking CD38, and you can see in this graph that there is a population of 3% of CD138, but majority of the cells, 34%, having one CD138. And the dilemma came, is this patient used DARA or anti-CD38 before coming to the hospital? And we find that he never used the drug, and this is first presentation. So the question was about how accurate we are in the lab to give that CD38 negative cells on patient who's first presenting with the plasma cell leukemia. And we know that it should be 138 and CD38 positive. And because the assessment has been done and the validation has been done very properly, and we know what antigens and antibodies that we are using, we test it again and find that it's corresponding. With the immunohistochemistry, it shows also CD38 negative for majority of plasma cells that in the bone marrow trifine. So, and just I will take 1 minute just to go with the recent development of the in the flow cytometry application. The ability to analyze 8 or more colors, fluorescence with high throughput quantitative analysis, allowing to measure the disease, the measurement of minimum residual disease, not only for acute leukemia, it's also for multiple myeloma and lymphoma that has been proved recently of prognostic values. Also, the use of the flow cytometry in the CAR T-cell therapy and follow-up of patient after infusion has been studied, but has several challenges that need to be taken in consideration when you start something in your lab, start the flow cytometry in your lab for those patient post-CAR T-cell therapy. This has been published recently in 2021 in May by the Swedish group. You can go through it. And finally, the imaging flow cytometry, where you can characterize the cells with the immunophenotype by seeing the cell's characteristic size and the shape, plus the immunophenotype. This has been studied very well by Dr. Wendy Erber from Western Australia, and she has a lot of publication about it. And she combined it actually with the fish as well, and molecular study. She did studies with acute promyelocytic leukemia and with NPM antigens, and her studies also in CLL and multiple myeloma has been published, where you can combine the flow cytometry specific cell antigens with the finding of the genetic test. That's my presentation. Thank you very much for listening, and I hope that you got aligned and targeted information from my side. Thank you.
I would like to thank Dr. Lubna for this very nice and comprehensive presentation, and we'll keep the questions at the end. And we, as love to Oman and Omani people, will give you 5 minutes, Dr. So we'll stick to the time for the next presentations. So our next speaker is Dr. Saeed Shayban. Dr. Saeed is our colleague, is a consultant anatomic pathologist and hematopathologist and working in King Abdulaziz Medical City National Guard, Saudi Arabia and Riyadh. He graduated from King Saud University Abha branch with a medical degree in '96. And then he joined King Saud University Fellowship in histopathology between 2011 and 2016. Then he did the postgrad training in Hammersmith Hospital, Imperial College, London. Following that, Dr. Saeed, he is currently working in National Guard Riyadh. He has more than 10 years experience in hematopathology with the main interest in lymph node pathology. Now, he has also more than 28 peer-reviewed publications, and we are very happy and delighted to have him here talking about this elegant presentation. Thank you.
Assalamu alaikum. Good morning, everybody. And I would like to thank the organizing committee for inviting me to give this presentation in this great meeting. imagine that I need to present T-cell lymphoma in 20 minutes, which I think it's major challenge for me. So what we will do in this session, I will just explore mainly the, highlight the classification of T-cell lymphoma. Then I will concentrate my presentation on the really very important and common topics, and I will leave the others probably for another time. So usually T-cell lymphoma, when we talk about the classification or the biology, it is usually linked T-cell lymphomas with the natural killer cell lymphomas because they are clonal neoplasm of mature and immature T cells and NK cells at various stages of differentiation. And both T cells and NK cells are closely related, and that's why they are lumped together in one classification, because they share some immunophenotypic and functional properties. When we look to the distinct entities in the WHO, in the current WHO classification of lymphoma, there are more than 30 types of neoplasms related to T cells and NK cells, which are grouped according to their usual presentation into usual clinical presentation into mainly 4 groups: the disseminated disease, the leukemic phase, and the extranodal group, cutaneous group, and nodal group. When we look to the, the prevalence and incidence of T-cell lymphomas, they are not like B-cell lymphomas. They are really uncommon. It's around 12% of all non-Hodgkin lymphoma. So just look at the distribution of T-cell lymphomas and NK lymphomas in the WHO classification. Although they are, relatively high in number, but peripheral T-cell lymphoma is the main subtype, and it accounts around 1/4 of all T-cell lymphomas. And that is not surprising, because usually people use peripheral T-cell lymphoma as a basket diagnosis for those T-cell lymphomas or NK lymphomas that I don't know where to put them. So usually we put them in the peripheral T-cell lymphoma. And when you look to the frequency, in the last 2008 classification, they were around 30%, but currently they are reduced to around 26%. The reason, because of the development of biology, understanding of the T-cell lymphoma. So some of the topics which were, or entities which were under peripheral T-cell lymphoma as a variants, they are changed from peripheral T-cell lymphomas to angioimmunoblastic T-cell lymphoma group, because they all share the same cell of origin. After peripheral T-cell lymphoma, angioimmunoblastic is the second more frequent one. Then the NK lymphomas, they are quite good in percentage. Then followed by the other. So in this talk, I will talk about peripheral T-cell lymphoma, angioimmunoblastic T-cell lymphoma. Then I will talk about anaplastic large cell lymphoma, and finally about one of the NK lymphoma, which is the commonest one, the nasal type. So these are the clinical groups where they were distributed according to their location at the time of presentation: nodal, extranodal, cutaneous, and leukemic. And you can see the different variants are distributed accordingly. So peripheral T-cell lymphoma, not otherwise specified. This is a heterogeneous group of nodal and also extranodal. Usually they are mature T-cell lymphomas which do not correspond to any of the specifically defined entities. That's why it is used as a diagnosis of exclusion. So you need to exclude others before you make the diagnosis of peripheral T-cell lymphoma. That doesn't mean they don't have their distinct morphologic or immunophenotypic features. No, but because again there is an overlap between the T-cell lymphomas generally in the morphology and immunohistochemistry, and also in the genetic profile. They are around 26% of all mature peripheral T-cell lymphomas, mainly in adults. And The site of involvement, most of the patients present with lymph node involvement. However, extranodal sites can also seen, like bone marrow, liver, spleen, and other sites. Usually the patient present with lymphadenopathy and sometimes with B symptoms. The morphology is very broad. So you can see, many different cellular appearance. But the most important finding is that the architecture should be effaced. So effaced architecture of the lymph node, broad cytological spectrum. Some of the cases, they show polymorphous population of tumor cells and non-tumor cells. Some of them are monomorphic, so the entire lymph node or the involved tissue showing lymphoma cells. Usually they are medium-sized or sometimes large size and irregular, pleomorphic, hyperchromatic, or vesicular nuclei with prominent nucleoli and many mitotic figures. Clear cells can also be seen. Cells that resemble Steinberg, Reed-Steinberg-like morphology can also be seen. Some of the peripheral T-cell lymphoma, they show blastic cells, so they resemble lymphoblastic lymphoma by morphology. And also some cells, they resemble or they show small cell variants. And even the nuclear feature, it's quite similar to those seen in Sézary syndrome. So really there is an overlap in the morphology between these different type of lymphomas. Rare cases, they have predominance of small lymphocytes as we mentioned. The background usually is polymorphic. They show eosinophils, plasma cells, and sometimes epithelioid histiocytes. Large B cells are also seen, and be careful because those large B cells, if you do IgHG rearrangement, they can show monoclonality. And this will confuse you, is this B-cell lymphoma or T-cell lymphoma? So you need to do both TCR and IgH probably to help you in addition to other findings to solve this puzzle. This is how it's present. This is an excised lymph node, and as you can see, there is a diffuse effacement of the architecture by the lymphoma cells. And also you can see proliferating vessels in the background. So don't confuse this with the vessels seen in angioimmunoblastic T-cell lymphoma, because those blood vessels, they lack the high endothelial cell morphology, the plumped endothelial cells seen usually with angioimmunoblastic T-cell lymphoma. If you go higher, you can see the proliferating or the monotony of the tumor cells. Also, you can see some of those pale cells which are histiocytes in the background. This is another view. You can see the diffuse effacement of the architecture. And if you go to high power, you can see now the polymorphic population of the neoplastic cells. Some of them are small, some of them are large, and even some of them, they look like RS-like morphology. Increased mitosis also seen, and you can see histiocytes, eosinophils, and sometimes plasma cells in the background. This is so it is not moving. Can you solve this, please? Okay. So this is another view. You can see the tumor cells here are polymorphic. Some of them even show a multinucleated cells, and some of them, like the one in the right side in the center, is funny shaped appearance. So the polymorphism is very obvious in these types of lymphoma. However, you can see most of the tumor cells, they show good amount of cytoplasm. So this is another hint that can help you to solve this issue. Next, please. I think this is not working. This is an example of peripheral T-cell lymphoma with blastoid morphology. So when you look at it, you will think, okay, that looks like a high-grade B-cell lymphoma like Burkitt's, or sometimes this is resembling lymphoblastic lymphoma because of this morphology. Even the tangible body macrophages, which commonly seen with high-grade aggressive lymphomas, is also seen with a lot of mitosis. So this is another spectrum of this type of lymphoma. So another variant, when you see increased number of histiocytes in the background of this lymphoma, so this is considered a special variant, the lymphoepithelioid variant, Lennart lymphoma. And why this subtype is important? Because it behaves better compared with the classical peripheral T-cell lymphoma. So you should recognize this and put it in your report, because this will help our colleagues in the clinical hematology to know that these kind of tumors are behaving well compared to the regular ones. Look at this example. You can see a lot of groups of epithelioid histiocytes, those pinkish cells. I'm sorry, I don't have laser in this, with me. So these pinkish cells are the cells the qualified for epithelioid histiocytes. When you see this morphology and you confirm it as peripheral T-cell lymphoma, so this is Leonard type. Again, next please. Okay. Immunophenotype, all lymphomas, T-cell lymphomas generally, you should do the pan T-cell markers. You should exhaust all what you have from your in your lab of as pan T-cell markers, because some of these lymphomas, they can show the entire panel. So all pan T-cell markers can be positive, but it is good to do that, because if you have at least one or more with partial loss or total loss of the expression of pan T-cell marker, so this qualifies for abnormal or neoplastic T cells. Usually in peripheral T-cell lymphoma, CD4 is more common expressed than CD8. However, some cases they can show double positivity, and some cases can show double negativity of CD4 and CD8. Sometimes GATA3 and TBX21 can be done, because currently there are a movement towards subtyping peripheral T-cell lymphoma into T helper 1 and T helper 2 according to the expression of GATA3 or TBX21. And this is really, it is not yet, confirmed. It's still debatable, but you should put that in your mind. Cytotoxic granules, TIA, perforin, and granzyme B can be mostly negative, but they can be positive. CD30 usually negative, but however it can be positive focally. CD56 usually negative, but sometimes you can see scattered positivity, but not usually the diffuse strong positivity similar to those of NK lymphomas. Rare cases, they can show EBV positive staining. Genetic profile, it is very complex genetic profile. However, it is not really specific. So you can see many karyotyping abnormalities and also a large number of mutations. However, TCR gene rearrangement is usually positive. Usually there is TCR gene rearrangement, which is not specific, but at least it will tell you that you are dealing with lymphoma. All right. Moving on to the second topic or second type, which is the angioimmunoblastic T-cell lymphoma. This is systemic lymphoproliferative disorder. It was thought to represent an abnormal immune reaction once or at the start of its recognition. However, those proliferation, they show TCR gene rearrangement. So they believe that it is regarded as T-cell lymphoma, not just a reactive process. It is related to the follicular helper T cells in the bone marrow. That's why the in the environment of the lymphoma. That's why the follicular T-cell lymphoma and the T-zone T-cell lymphoma are taken from peripheral T-cell lymphoma and put in one group with the angioimmunoblastic T-cell lymphoma, because all these three entities, they share the same cell of origin, the T follicular helper cells. Patients usually present with lymphadenopathy, with hepatosplenomegaly. They can also present with skin rash, effusion, fever, and polyclonal hypergammaglobulinemia and hemolytic anemia. Morphology, usually the architecture is effaced with polymorphic infiltration of small to medium-sized lymphocytes with a heterogeneous background of many reactive cells, granulocytes, eosinophils, plasma cells, fibroblast-like dendritic cells, histiocytes, and epithelioid cells. And it occupies paracortical or interfollicular area mostly. And the atypical T cells, they are usually round to irregular nuclear contour with broad clear cytoplasm with distinct cell membrane. Clearing here is very obvious and more commonly seen than peripheral T-cell lymphoma. Medium to large basophilic blast of B cells can be seen in the background, and usually those B cells are the cells infected with EBV, and probably they are the triggering factor for the development of this disease. However, those B cells also, they can be monoclonal irrespective of EBV infection. This is an example of a low power example of angioimmunoblastic T-cell lymphoma. You can see there are scattered reactive follicles in the center, and in the interfollicular area there is a huge or heavy vascular proliferation with the abnormal T cells. When you go higher, sorry. Okay, so when you go higher, you can see, anyway, you can see the proliferating small to medium lymphoid cells with clear cytoplasm, and they are really associated with the proliferating fizzles which show plumped endothelial cells qualifying for high endothelial lymphocytes. You can see here at the upper right corner there a binucleated large cells. Those are actually the abnormal B cells seen in the background. Even sometimes they can look like Reed-Steinberg cells, and they are CD30 B cell, CD30 positive B cells, and also they can express EBV. So immunophenotyping, again, pan-T-cell markers should be done. There may be complete or partial loss of one or more of the T-cell markers. Usually they show T follicular helper cell immunophenotype. So CD4 positive, CD10 positive, BD1 and BCL6 may be positive. In addition, CXCL13 is another T follicular helper cell marker. It can also be positive. Another findings, which is very important, is to highlight follicular dendritic meshwork proliferation in the background of the abnormal cells. Usually they are even encasing the proliferating blood vessels. And this is to differentiate these areas from follicles, because follicles, they don't have these proliferating or high endothelial cell vessels. If you see follicular dendritic meshwork in a background or encasing blood vessels, this is usually outside the germinal center, and this will qualify for the diagnosis of angioimmunoblastic T-cell lymphoma. Large B cells, they can be positive for CD30 and B cell markers, and EBV positive. Plasma cells in the background, usually they are polyclonal. This is another example. You can see a follicle surrounded by proliferating lymphoid cells with proliferating high endothelial cells, venules. They are CD3 positive. Look to CD20. This is another helpful hint for you to diagnose angioimmunoblastic T-cell lymphoma. Usually the proliferating environment, they push B cells or the cortex to the periphery, to the subcortical area. That's why CD20 has this funny appearing morphology. If you go high power to CD20, the last upper image, you can see also the large CD30 positive B cells, which also show CD30 positivity here, and they are EBV positive. You can see CD10 scattered positivity in the tumor cells, indicating T follicular helper cells, and the CD23 at the end there, showing the proliferating expanded matrix follicular dendritic cell meshwork in the background of those venules. This is another example. You can see the proliferating cells are CD3 positive and T follicular helper cell positive PD1, which is the greatest marker among those to highlight the TFH and proliferate and expansion of follicular dendritic cells by CD21. Genetic factors similar to peripheral T-cell lymphoma. It is very complex and it is really non-specific. However, they show more than 90% TCR rearrangement. B cells, they can show IgH gene rearrangement in around 15%. And okay, good. And many of these translocations and mutations involve many genes which are not really specific to this lymphoma, but they do exist. Follicular T-cell lymphoma is another variant of this group, the angioimmunoblastic T-cell lymphoma group, and usually they are very, distinct architecture. They look alike follicular lymphoma. And you see follicles appearing or cellular nodules, but when you go high power to those cells, they don't show centrocytic centroblastic morphology. They show an irregular abnormal cells with visible nucleoli and abundant cytoplasm. And when you do CD21, you can see again the positive expanded follicular dendritic meshwork in the background. However, the endothelial cells, they don't show the high endothelial morphology, the plumped endothelial cells seen in angioimmunoblastic T-cell lymphoma. This is another example of follicular T-cell lymphoma. I just want to show you here F, which is CD10 strong positivity, and here BCL6, and also PD1 strong positivity, indicating T follicular helper cells in this group. Next, please. Anaplastic large cell lymphoma. This is again an important entity. It consists of lymphoid cells that show the typical hallmark cells, and we will see them in a while. They can be ALK positive or ALK negative, and must be distinguished from cutaneous anaplastic large cell lymphoma, because cutaneous is behaving much better than the systemic variants. I'll go to the morphology. So this is how they appear. They are large anaplastic morphology. Most of the cells, they show C shape or kidney shape with abundant cytoplasm. These are the hallmark cells. And interestingly, they can only show sinusoidal distribution. So they can fill up the sinuses. They can also show only sinusoidal distribution without parenchymal involvement, and can be confusing with metastatic carcinoma, or you may miss it because you sometimes when you evaluate the lymph node, you miss to look to the sinuses. So it is important to look to the sinuses when you evaluate lymph node biopsies. Okay. So they have many variants. There are small cell variants, there are the common variant, the hallmark cell variants, Reed-Steinberg morphology. There are many variants, but one of the important things is this variant, the Hodgkin-like morphology. This is a case, when you look at it, you will think this is nodular sclerosis, Hodgkin lymphoma. Sclerosis and those nodules and the tumor cells, they show like the lacunar cell morphology. So without immunohistochemistry, you can say, okay, this is nodular sclerosis, Hodgkin lymphoma, but be careful. They can resemble nodular sclerosis. And if you do immunohistochemistry properly, you will see they show the immunophenotyping of anaplastic large cell lymphoma. In this example, you can see ALK positivity in this case. So ALK positive or negative, this will give you the subtype. The other markers that are important, CD43 can be positive, CD30 should be strong and diffuse positive with membranous and Golgi appearance. EMA may be also positive. Okay, ALK positivity by immunohistochemistry is usually related to what translocation this patient has. The common translocation, which is T translocation 2.5, 2 is the area where ALK is located. So usually it shows membranous, the full nuclear, cytoplasmic, and membranous. If you see only cytoplasmic strong, that is usually alternative translocation, either translocation 1.2 or translocation 2.17, which show only faint granular positivity. The message here is any positivity is acceptable. It depends on what translocation is there. Lastly, I will just talk about the morphology and immunophenotype of extranodal NK T-cell lymphoma nasal type. This is an aggressive, usually or always extranodal. If you see it in lymph node, that is, you should be careful. And usually they are now provisional diagnosis is primary nodal T-cell NK lymphoma, until it's probably with the next classification, it be a different, a specific entity. So these actually show blastoid morphology with a lot of ulceration, a lot of necrosis because of the angiodestruction. You see, the NK lymphomas, usually they like to attack blood vessels, angiocentricity or angioinvasion, leading to ischemia at the site of the tumor. The immunophenotype is very classical. Usually these lymphomas are CD5 negative. Usually they are CD56 positive, strong, because they are NK. Usually they show cytotoxic granules positivity, like in this example, granzyme B, and usually they are EBV positive, and EBV EBR not the LMP one. EBER is a must to perform before you rule in or rule out NK lymphomas. Okay, that's it. Thank you very much.
Thank you, Dr. Said, for excellent presentation on the topic of challenging and the important T-cell lymphoma, which we usually facing challenging in diagnosis and subtyping. So the next speaker is Professor Mohammed Gari. Professor Mohammed Gari is well known for everyone in Kingdom of Saudi Arabia. He's graduated from King Abdulaziz University, Jeddah, and he carried on his residency program in Riyadh Military Hospital, which is now Prince Sultan Military Hospital in Riyadh, and then finishes hematopathology fellowship and ending with FRCBA. Dr. Gary is a president of various scientific organizations such as Saudi Scientific Hematology and the Pan-Arab Hematology Association. And at the same time, he is a chairman of Hematology Department, King Abdulaziz University. Dr. Gary is well known for everyone in our society, and he is active, very active in participation in the community and research. Welcome, Dr. Gary.
Assalamu alaikum warahmatullah. I know that we are behind in time, so I try to be fast. I have to skip some few slides to remain within the schedule. The reason why I chose to speak about splenomegaly beyond the common problems is that Gaucher is a disease that is often linked to splenomegaly. And we normally, within our heavy and busy practice, we forget to look for Gaucher disease and we may miss some cases. I personally missed one case one day, and then I remembered, I rectified the situation, and it's done. But I think it's very important to remember that it is linked to splenomegaly, and it's among the few things that we normally should think ahead when we see spleen enlargement. We should think of Gaucher. I talk about various points in general related. This is Philippe Gaucher. In 1882, he described the first case, and then subsequently he discovered a similar case of Gaucher. So he was linked to the name of Gaucher, this disease. In the epidemiology side, it's the most common lysosomal storage disease. It's a progressive, heterogeneous, multisystemic disease leading to debilitating, life-threatening conditions, and it is an autosomal recessive of inheritance. It's normally due to the deficiency of acid beta-glucosidase. This is before it was called named glucocerebrosidase enzyme, but the new name is acid beta-glucosidase. It's characterized by engorged macrophage, which are often named the Gaucher cells. This is a lysosome where we normally dispose many of our cell constituents to be degraded and removed. This become engorged, and the cell itself will be filled with lysosomes like this, and all of them will cause enlargement. If you put lysosomal storage disease, you will see that 14% of all the lysosomal storage disease are due to Gaucher, and then followed by mucopolysaccharidosis, several types, Fabry, and Pompe disease. The rest of the lysosomal storage disease are there, but they are less often encountered. As any autosomal recessive disease, we will see that there is a chance, and it's only statistical chance, not the truth, not the actual fact. We see 25% Gaucher patients, carrier in 50% of cases, and normal in 25% of cases. Parents normally carrier of the mutation of Gaucher have a 25% chance of having a child. They may or they may not have this. We should offer genetic testing for the family members in suspicion of this disorder. The overall population of the Gaucher disease is surprisingly higher than what we thought. It is 1 in 40,000 to 1 in 60,000 in any population. However, it is most common Ashkenazi Jews, making 1 in every 850 individual. And 80 to 90% of the mutation are in this population of the Jewish Ashkenazi, and 50-60% mutation is detected in the non-Jewish, and it has several types from very mild to severe cases. In the pathophysiology, we know that the deficiency of any enzyme is an inborn error of metabolism that leads to deficiency of the substrate and accumulation of the substrate and deficiency of the product. This is what's going to happen. You will see that this is the Gaucher cell in the center. It's filled with lysozymes. There's a storage of glycosyl ceramide, primarily in the cells of the monocyte macrophage. There is a progressive multi-organ dysfunction because we all know that macrophages normally reside in many organs, including the liver, the spleen, and other sites. So these are the sites where we can see. Gaucher cell is very characteristic cells. Normally in morphology, it's often called onion skin appearance because of the arrangement like a halo around the nucleus. So we know that the bone marrow infiltration will give rise to monocytes being expelled out of the bone marrow, and then they will be termed or named macrophages. In the spleen, this will cause massive splenomegaly, cytopenia, and hypermetabolic state. In the lungs, it will cause infiltrative lung disease. In the bone marrow, it will cause many complications, and in the bone itself, osteonecrosis, osteoporosis, pathological fracture, chronic bone pain, and in the liver, it will cause enlargement with many Kupffer cells being accumulated in the liver. To classify Gaucher, simply, it is the neuropathic type and non-neuropathic type. Of course, the neuropathic type is more difficult to treat, it's type 2 and 3. It is less often encountered, 1 in 100,000, compared to 1 in 50 to 100,000 worldwide for the non-neuropathic type, which is normally more common, and the clinical manifestation possible at every age, while in type 2 and type 3, it can, in type 3 in particular, manifest in early childhood. Type 2 is the worst. It can kill the child due to the very early presentation at a very young age. Again, this is the same thing. Type 1, non-neuropathic, less common. It presents at any age. Lifespan is variable. And this is just to remind us that if you see spleen in an adult 40, 50 years old, still there is a chance that he has Gaucher disease. So one has to offer them a chance of being detected. And there is different complications. As you can see here, primary CNS disease, you can never see. Visceromegaly, hematologic abnormality, skeletal abnormality are there, but they are less common, less comprehensive and less severe than type 2 and type 3. Type 2 and 3, you can see mild to severe. In type 3, in type 2, you can see severe neurological pathology, and this can be fatal sometimes, including the other complication that we discussed. Less often, type 2 and 3, more often in type 1, the presentation and the incidence. The clinical manifestation, of course, naturally is going to follow the development of the patient and the growth of the patient. So in a child, you will see more remarkable hepatomegaly, splenomegaly, anemia, and thrombocytopenia, while there are some other general manifestations, including growth retardation, pulmonary hypertension, neurological symptom in type 2 and 3 in particular. And there are less often seen bone manifestation because the bone manifestation tend to present at a later age. In Gaucher, in adulthood, you will see now the appearance of the bony complication and manifestation, including the bone pain, bone crisis. Of course, the hepatosplenomegaly, anemia, and thrombocytopenia are there. We'll see Erlenmeyer flask deformity, pathological fracture, joint collapse, and osteonecrosis and other complication related to the bone. So with the development, the complication become more manifest. As you can see here, this is some of the x-rays showing the different deformity that we discussed. Patients sometimes may present at adulthood with the bony manifestation to the orthopedic surgeon, and then they are detected, they are referred to hematology and the doctors in charge. The bone involvement in Gaucher disease is associated with infiltration with the Gaucher cells, but a real mechanism of the bony complication is not very clear. The extent is variable from patient to patient. The hematological and visceral manifestation may be silent. Patient may not report their symptoms adequately or obviously as they should be. The extent and severity of the skeletal manifestation has a very poor correlation with the genotype of those patients. In the differential diagnosis, it is very surprising, as you will see in the next slide, that patient with thrombocytopenia, anemia, hepatosplenomegaly, and bone pain, normally we should think of the leukemias, lymphoma, myeloma, hematological malignancy. Sometimes we think of myelofibrosis, and rarely we think of Gaucher disease, when in actual fact, we have to bring it into our attention. So there is an inherent problem with Gaucher, that the awareness about Gaucher disease is less than one is expected. What should be considered in a patient like this, splenomegaly and or thrombocytopenia, should be tested for hematological malignancy, as in the previous slide, should test for hemolytic anemia, Gaucher disease, ITB, splenomegaly due to portal hypertension. One should think of all these broad categories and direct his investigation and clinical approach to these problems. And of course, sole thrombocytopenia or solo splenomegaly are merits for investigation for one of these differential diagnoses, or both of them, splenomegaly and thrombocytopenia. As you can see here, and there are a real reason behind putting Gaucher in the differential diagnosis of hematological malignancy. The truth is, Gaucher disease shares many of the manifestation with acute leukemia, myeloma, lymphomas, and myelofibrosis. You can see that the manifestation can be shared, so one has to put it upfront and remember to test for it. If you fail to detect any hematological malignancy, then resort to Gaucher disease. To diagnose those patients, the clinical manifestation are there, so you should be able to pick up some of the manifestation correlated with abnormality, like Gaucher reflect the cellular site of the lipid storage and chronic macrophage activation, because this is where the disease is. The simplest way to diagnose Gaucher disease is to do the dried blood spot test. Dried blood spot test will tell you the enzyme activity. If you detect a deficiency of the enzyme level, you should resort to the molecular testing. But it's very interesting to say that in one survey, which involved many hematologists, I will show in the next slide here. This is a study where 406 doctors from different countries were offered this scenario: 42 years old male presenting with anemia, thrombocytopenia, hepatosplenomegaly, and bone pain. Look at what the people thought of: leukemia in 65%, lymphoma in less, multiple myeloma, and only 20% of the doctors put Gaucher in their differential diagnosis, and even less for the bleeding, and others they did not show any answer. So it is very important to remember one fact, that Gaucher is even a disease that is forgotten. It's not in the front of our brains to remember as a differential diagnosis. The impact of late diagnosis is so huge and immense to the patient. The patient pays a very heavy price for delayed diagnosis. We will face premature death, pulmonary hypertension, liver disease, sepsis, growth retardation, complication of the bone disease, and very huge impact on the quality of life. Again, the diagnostic testing include the enzyme level on the dried blood test, a dried blood spot test. This is offered free from Sanofi Genzyme. They have no obligation to you. If you do the test, they will offer it for free. There is no obligation for you to use their product or use anything else for the treatment, but it's offered as a service for patient. Then the next step is to do the gene mutation analysis, molecular testing to diagnose Gaucher disease. Finally, in the old days, people did bone marrow aspiration to see the Gaucher cells. This is not anymore the case. You can do this dried blood spot test to detect the cases. And if you find positive case, you need to confirm that by molecular. And this is, again, is offered as a service from the same company producing the treatment. So they offer both the dried blood spot. If there is any deficiency, they are going to do straight away the molecular testing. Which prognostic marker you are going to use? The common prognostic marker is glycosyl sphingosine. Why? Because it is increased in 100% of Gaucher cells and correlates very well with the level of the clinical complications. It correlates with the severity, and those biomarkers themselves are not diagnostic. They are only meant to you to follow up the cases. The goals of the treatment is to eliminate anemia, reduce fatigue, reduce the blood transfusion. For thrombocytopenia, you need to maintain an adequate platelet count. For the organomegaly, you need to decrease the pressure and the size of the organ, relieve the abdominal pain. And finally, the skeletal manifestation, normally difficult to treat. They need surgical intervention sometimes, and they are meant to lessen the bone pain, prevent the bone crisis, and to improve the bone function. The only treatment that is approved as a standard of care by ERT is immunoglycerase. It has two decades of safety and efficacy. There is good confidence. About 5,600 patients worldwide are using the treatment. The dose is individual. It's variable from 15 to 240 milligram given IV infusion over 1 to 2 hours once every 2 weeks with a well-documented response. Safety and efficacy data include the immunoglycerase has a robust long-term and real-world data. This is just to show you after 4 years of immunoglycerase therapy, how much is being achieved for the hemoglobin level. It is increasing significantly. Platelet count is seen to be increased. The green shows that after 4 years, the yellow is in the baseline, and then the liver volume reduced. There is an improvement of double the size. It became 50%. The spleen volume dropped, and also the bone pain and the bone crisis are less often encountered significantly in those patients. The improvement after you start the treatment starts from the end of the first year. As you can see here, these are two markers, the bone pain and the bone crisis, which are one of the worst complications of Gaucher. The bone pain and the bone crisis start to improve after the end of the first year. This study went for 3 years, and the patient maintained the improvement over the 3 years period of the study. The early intervention normally, as I said, is very important to decrease the incidence of avascular necrosis. As you can see here, you can drop 41% decrease in the risk of the problem compared to patients who are starting treatment after 2 years. So the early intervention, not only the diagnosis and the treatment, but it's very important is when to start treatment, and you have to start it as early as possible. Finally, the long-term of immunoglycerase results in the clinical improvement. This is a 10-year study showing that there is a remarkable improvement in the anemia, shown in the green, thrombocytopenia, hepatomegaly, splenomegaly, bone pain, and bone crisis. And this is showing that the longer we maintain the treatment, the better is the outcome. The immunoglycerase is approved for EU in the non-neurological manifestation of the Gaucher type 3. This means that the type 3 in particular, we do not expect remarkable improvement in the outcome of those patients related to the neurological complication, but we can achieve better outcome for the rest of the parameter, including splenomegaly, anemia, and thrombocytopenia. There is early onset of prominent visceral hematological disease, striking growth failure. The data from ICGG, the Gaucher registry, demonstrate these effects are reversed within 5 years, and patients with type 3 improvement in non-neurological signs and symptoms, similar to those experienced by patients with Gaucher type 1. So you can achieve very good outcome, similar to type 1, which is easier to treat, but not in the bony manifestation. And the probability of surviving at least 5 years after starting immunoglycerase was 92%, and probability of living up to 20 years is 76%. In summary, this is my last slide. We have to remember that hematological malignancy overlaps with Gaucher disease in their clinical feature, particularly thrombocytopenia and splenomegaly, or both of them. Awareness to the physician in the front line will change the outcome. So everybody should remember this name, Gaucher disease, and put it in the list of their differential. Early diagnosis, not only diagnosing patient, but early detection and diagnosis will reflect remarkably on the outcome. Patient with splenic thrombocytopenia should be offered the free testing to Gaucher disease. Diagnosis achieved with enzyme assay and genetic testing. Awareness can save life and improve the quality of life of those patients, and the socioeconomic impact is huge. I just want to end by reminding you with the fact that Gaucher is a disease that exists. It is not extremely rare. It is seen sometimes, but if you don't remember it, we will definitely miss it. Thank you very much.
Thank you, Professor Gary, for this elegant and comprehensive presentation about splenomegaly and Gaucher disease. And I would like to invite the speakers to come to the stage for questions, and would like to open the floor for any questions to our speakers. Any questions? Question at the back? Yeah. Okay. There's a question at the back. Can you raise your hand if you have any question? And about mean bad and.
Thank you so much for this interesting session. Prof. Kari, thank you so much for the Gaucher session. It's really interesting. Yes, we are we need more orientation of Gaucher incidents, because most of us are directed into the diagnosis of leukemia or ITP. Splenomegaly or thrombocytopenia or bony aches should grab our attention to do the Gaucher tests. Our field in practice is a pediatric oncology hematology. The use of imiglucerase in pediatrics, how is the long-term side effects and how much does it affect on the life expectancy and the complication load on the pediatric Gaucher patients? And what about the cost effectiveness? For sure, it is effective for cost, but how much does it cost here? Is it available locally here or not? Long-term side effects in pediatrics. Thank you so much.
I think we should start by detecting patients. It is uneasy to talk about the availability of the medicine when we don't offer the testing procedure. It's very important, the take-home message, that try to think of this disease as one of their differential, not necessarily the most common, but it is there. It's an existing. So if you don't detect it, you cannot treat it, and the complication will last with the patient his lifetime. So diagnosis, early diagnosis, and then if we don't have this treatment in every hospital, and it is not the case that you should have it in every hospital, there are specialized hospitals that offer the treatment free. So we should be able to send those cases in case we fail to bring the medicine to those hospitals of ours. I think in our hospital, to be honest, it's not there. But if we have a case, we can order it for this patient, but we should start by early detection.
Thank you, Prof. Kari. Thank you.
Thank
really
you.
Right.
Dr. Darwish, over there.
Assalamu alaikum. Dr. Mohammed Darwish from King Fahd Specialist Hospital, Dammam. I have two questions to Dr. Saeed about the, you said about the T cells having possibility of background of B cell that can even have an IgH rearrangement. So in this case, we will have T cell rearrangement as well as IgH rearrangement. How would you make sure this is not a B cell, this is a T cell still? And or even undifferentiated between, or both of them coexist? This is one question. The other question is, can we have an NK cell with negative CD56? Thank you.
Thank you very much. These are actually very important questions. For the first question, yes, these kind of tumors where IgH can be positive in around 20% or 15% of cases. However, as you know, in lymphoma diagnosis, we don't depend on only one parameter. It should be the 4 parameters together: the clinical, morphology, immunohistochemistry, and genetics. In this kind, or in this regard, all the context is going to T-cell lymphoma by the morphology, immunohistochemistry, and also the clinical presentation. Even if the IgH is rearranged, which is usually less common than rearrangement of T-cell TCR in reactive non-neoplastic condition. However, these shouldn't be considered as neoplastic B cells. They are just triggering factors in the background of the T-cell lymphoma, and you should take all the parameters together. For the second question, yes, there is extranodal NK T cell lymphoma, nasal type with CD56 negativity. We do see these cases. However, in these cases, you should have two findings that support the diagnosis of NK lymphoma. It should be EBV/EBR positive, and there should be cytotoxic granules positivity in these cells, either using TIA, granzyme B, or perforin. If you have those are positive, even if CD56 is negative, this considered as extranodal NK T cell lymphoma. And this is actually the T part of this lymphoma, because it is NK and T cell. So these 56 negative cells are usually the T component of this entity. I hope I answered your question.
If I may add a comment, just a comment. We have a lot of cases that have been diagnosed with certain type of T cell lymphoma. And when REBC changed the diagnosis, I think this adds to how much difficult it is to subcategorize the T cell lymphoma. Just a comment.
True. It is an uncommon. That's why it is difficult to diagnose.
Dr. Ghalib, have a question. Please, question, Dr. Ghalib. Thank you, speaker, for excellent presentation. Actually, I have a lot of questions, but I will summarize just in two questions for Dr. Lubna. The first, we do flow cytometry is strong tools in hematological malignancy diagnosis. Can you just highlight what is the limitation of flow cytometry in the field of lymphoma and leukemia? Limitation of flow cytometry in leukemia and lymphoma.
Well,
I mean, difficult to diagnose by flow cytometry, false positive or false negative result.
Yeah, as I mentioned in my presentation, although I highlight a lot of practical laboratory practice, it's very important to us in the lab to set all these parameters to eliminate many of the false negative and false positive. This is one of the things that we have to set it in the lab before we take the sample. Many things comes from pre-analytical, that's the sample quality that we receive, and specific, certain careful or certain consideration has to be taken while you're sending the sample for the lab. From cases like lymphoma or multiple myeloma, for examples, as I mentioned, that we need to have the first draw from the bone marrow, and we need to take it immediately to the lab to do the testing. So the limitation actually, it's also passed through the 3 stages that I mentioned: pre-analytical, analytical, and through the data interpretation. If we have a good sample, if we did properly transported, and we have already our lab set it very well in the flow cytometry and validated, the things goes much easier in interpreting of the result. Okay, and the chance of false negative, false positive rely on how much the data we got it. It's very broad, question, and it's very broad topic. And it was very limited time for us to talk about it. But if we take, if I talk an example, for example, if you're talking about MRD, we have a lot of, or just MRD. You need to have the sample, as I said, the first one comes from the bone marrow, and you have to assess it quickly in the lab, and you have to set your panels already there. Your data interpretation based on how much event you acquired. So if we for MRD, the lower limit is 500,000. So to get that, you have to have a good sample, okay, and you have to have good viability of these cells. And then based on your antibodies and your panels that you're choosing, you can detect the MRD. So I hope that in each section in hematology actually or disease, we have limitation, But with the improvement of the flow cytometry validation and standardization and antibodies that we coming across every now and then, and using of more than 8 colors,
Thank you.
flow
Very clear.
cytometry, we are getting
thank
it much better.
Next question, yeah.
Okay, due to time limitation, I will keep my question to Dr. Said between us because I have a lot of question already, but I will ask Dr. Gary, in your clinical practice, who is the patient who's you requested for Gaucher after exclusion of hematologic malignancy?
I think any single patient with thrombocytopenia should be considered for Gaucher. Any patient with splenomegaly should be in the differential diagnosis. We should incorporate Gaucher or both, any thrombocytopenia and splenomegaly. This is the very simple answer, that one should remember Gaucher when we see thrombocytopenia, splenomegaly alone, or both of them.
So if you have a patient is clinically diagnosed ITP for first time, did you look for Gaucher or you have to?
I do. Any single thrombocytopenia in our department, we have this service. We do it. It's free of charge. It's not going to make you lose anything to incorporate it in your differential diagnosis, but at least you give the patient chance to be detected, because ITP, but as the name implicates, it's idiopathic. So we are dealing with something idiopathic. We try to bring light into the darkness by testing for different possibilities.
I think this is it for the questions and discussions. And I would like to thank our elegant speakers for their time and effort and elegant presentations, Dr. Saeed, Dr. Lubna, and Professor Gary. I would like to thank my co-chairman, Dr. Yamani, for this moderation. And thank you all. We'll conclude this session. We already have 30 minutes of your break time. Thank you.
Okay, thank you so much. So as much as we can squeeze our time to come back, because the organizers are sticking to the timings. Thank you so much.
Please, we will take a group photo. If you are interested, please join us here to take a picture. All are invited for this group photo. Please come. سلام تفضل يا الحال. اسألها.
Inviting every members of the faculties or speakers to have the group photo. Speakers, session speakers, and I think you need to come up to the stage though, but it's difficult. It's so difficult. It's so, the height is so, better. There's a stair there. Yeah. Go ahead, doctor.
transplantation, working at Prince Sultan Military Medical City in Riyadh, and I am the Vice President of the SSBMT. I have my colleague, Dr. Mohammed Al-Isa. He's a consultant pediatric hematology oncology and bone marrow transplantation at National Guard. We're going to moderate this session. We have 3 speakers. I will start with the first speaker. It gives me great pleasure and honor to introduce Dr. Wasil Justiniya. I'm sure everybody knows Dr. Wasil. He's well known locally, internationally, and nationally and internationally. So Professor Wasil, he is a pediatric hematology oncology and bone marrow transplantation. He is currently the chairman of the oncology at King Faisal Special Hospital and Research Center in Jeddah. Formerly, he was the chairman of the Prince Noura Oncology Center at King Abdulaziz National Guard. Professor Wasil, he is a double board certified, both pediatric and pediatric hematology oncology and BMT. He has the American board as well as the Canadian board. So Professor Wasil, he has been on numerous awards and distinguished and held multiple leadership roles. It has been a member of multiple national and international society, and he is also is well published in the field of pediatric hematology oncology, and he has been invited speaker at several international congresses. He is currently research interest in the acute leukemia as well as the hemoglobinopathy, particularly in sickle cell. Professor Wasil will talk us about the management of persistent MRD in pediatric. The floor is yours, Dr. Wasil. You have 20 minutes.
السلام عليكم صباح الخير ولا good afternoon بدل صباح الخير. Thank you for this generous introduction. It's really a privilege and an honor to do this live face-to-face and see faces of friends and colleagues in this meeting rather than talking behind the screen to a machine. So it's really a pleasure to be here. It's also challenging to get used to the stage again and to talk and see faces again while you're doing the talk, but it's also challenging to talk about MRD management in ALL in general when we still don't have a clear-cut management decision. It's also challenging to talk after lunch because of the postprandial syndrome. So there's many challenges that I have to go over here, so please bear with me. First, I'd like to make a disclaimer that this talk will focus on the management of MRD positivity in the frontline therapy setting for Philadelphia negative pre-B ALL. And this is an important disclaimer because what I will attempt to do in this presentation is to show you that one size does not fit all when it comes to MRD management. It's also important to recognize this in the era of precision medicine, and MRD is one of those tools that have made precision medicine possible, particularly in ALL. So I'll start with a quick introduction, a quick welcome to Dr. Najla, and to the Children's Oncology Group approach, the NCCN guidelines for pediatric MRD positive ALL, and then quickly mention my approach or how I would suggest to manage MRD positivity in ALL. So quickly, despite 80 to 90% of patients with ALL achieve a hematological remission after induction and consolidation, still a good number of patients remain MRD positive. So up to 50% of adult ALL in hematological CR will exhibit MRD positivity, and up to 20% of pediatric ALL in CR will exhibit MRD positivity. So MRD positivity is not uncommon in practice. And we know that MRD is a prognostic marker for pediatric and adult ALL. It strongly predicts overall survival and event-free survival and is considered the strongest predictor of a relapse in both adult and pediatric ALL, as shown in this meta-analysis that included more than 13,000 patients. The question arises is that we know that it's prognostic, but is there evidence to support that MRD-based risk-directed treatment improves outcome? In particular, is there evidence to support that reducing therapy for MRD-negative patients would improve outcome? Or and on the other side of the coin, is there evidence to support that escalation or change of therapy for MRD-positive patients would improve outcome? And I'll tackle these two questions in the next few slides. So first, reducing therapy for MRD-negative patients. The COG 0932 study included NCI standard risk patients, i.e. patients that are 1 year of age or older, but less than 10 years with a white count of less than 50,000. This study it recruited patients between 2010 and 2016, and standard risk low patients were defined as patients that had favorable cytogenetics, meaning ETV6 RUNX1 fusion, or harbored a double trisomy of chromosomes 4 and 10. These patients were CNS1 status at diagnosis, and their day 8 peripheral blood and day 29 MRD from the bone marrow was less than 0.01%. The question asked in this particular group is whether choosing low-risk regimens, the 0331 regimen or the P9904 regimen. And the COG 0331 regimen was called as the low-risk C regimen, and the P9904 regimen was called as the low-risk M regimen. And this latter regimen had no anthracycline, no alkylators, but incorporated 6 doses of intermediate dose methotrexate of 1 gram per meter square with leucovorin rescue. The results were published recently, and it showed that both regimens had an outstanding outcome with a disease-free survival of approximately 99% in both regimens and an overall survival of 100%. However, the LRC regimen had more significant mucositis and allergic reactions as a result of the anthracycline alkylators and the pegasparaginase that's included. But the study concluded that we can select with MRD and genetic interactions a population that can be almost certainly cured with lower doses of chemotherapy. However, which method to use? The COG always used the flow cytometry as the method of MRD, and we know that MRD methodology has been evolving over the years, from morphology to flow cytometry that can detect a certain level of measurable residual disease. PCR in certain subtypes can go to even 1 log higher sensitivity when compared to flow cytometry. And more recently, the high throughput sequencing or the next generation sequencing using the clonal sequencer can detect up to 1 in a million cells in terms of measurable residual disease. But does the method and the sensitivity matter? And this was one of the questions that this study asked. This is accumulated data from the COG 232, which included high-risk patients, and the 0331 trial that included NCI standard risk patients. And as you can see from the red arrow here, patients that were flow MRD negative, but were positive by next generation sequencing, or what's called here high throughput sequencing positive, had a significantly lower survival compared to those that had HTS MRD negativity. So this study concluded that there was first a high discordant rate between HTS and flow cytometry, where almost 40% more patients were positive by the HTS method, or the next generation sequencing method for simplicity. Not only that, NGS was able to significantly stratify patients for 5-year EFS and OS in both standard risk and high risk patients. Not only that, interestingly, when they piloted NGS testing in the standard risk group, incorporating the 0331 at any threshold, if there was no MRD by HTS, these patients had an EFS of 98% and an overall survival of 100%, which is something that you rarely see in cancers of 100% survival. And this included patients with both favorable, the ETV6, RUNX1, and the double trisomy, or those without favorable genetics, indicating that the more sensitive measure you have to measure MRD, the better the outcome or the stratification that you can achieve. But does this apply for all? And I promised I will not talk about Philadelphia positive, but this is one exception to the rule, just to highlight a point that when you choose the method, it has to be a validated method and it has to be a reliable method. And this is an example where MRD in pediatric Philadelphia ALL MRD testing, they compared in this COG ALL 112 to 3 different methods: the BCR-ABL1 PCR method, the immunoglobulin T-cell rearrangement PCR method, and the flow cytometry method. And as you can see from the red boxes, the one that really had the best concordance was the immunoglobulin T-cell rearrangement and the flow cytometry. And however, the BCR-ABL, which should be more specific and more quantitative, was not reliable as flow as backup. In fact, transplant decisions could be made in 98% of patients by flow cytometry MRD, 84% by the immunoglobulin T-cell rearrangement, but only in 40% of those positive by BCR-ABL1. So the study that was published in abstract format only concluded that for patients not enrolled on a clinical trial, using flow for MRD assessment is perhaps the most practical method in North American centers. However, NGS was not tested in this particular or validated in this particular population. A similar study from the European group, the SFAL 2004, compared the same thing, but they only compared MRD by BCR-ABL and MRD by the immunoglobulin T-cell rearrangement. And what they were able to show is that there was an overall concordance between the two methods of approximately 70%, but 30% of cases were not concordant or they were discordant. And majority was because of positivity of BCR-ABL, but negativity by the immunoglobulin T-cell rearranged PCR. And this did not impact outcomes. So they concluded that from our data, IGTR MRD monitoring appears to be more reliable. So further validation of BCR-ABL in the Philadelphia positive ALL is required. And this is different than when we talk about CML. So it's probably a different disease with different biology, and the false positivity of the BCR-ABL needs more study. So with that in mind, let's talk about the other question. Is there evidence to support that escalation or change of therapy for MRD positive patients improves outcome? And there are 3 studies that I will highlight. The UCAL ALL 2003 study that randomized patients with MRD positivity into a standard arm or a more intense arm, which is called the regimen C, that included more pegasparaginase, more vincristine, and more doses of capizi methotrexate compared to the standard arm. This study showed that augmenting therapy does have a beneficial effect on overall outcomes when you stratify patients to intensive therapy by end of induction MRD of 0.01% or greater. However, augmentation of therapy was associated with more adverse events than standard post-remission therapy. This was also shown in a COG trial, the ALL1131, that incorporated clofarabine as a mode to intensify chemotherapy for MRD positivity at end of induction. And the study was halted early because patients that had more intensive chemotherapy with clofarabine had more toxicity that was considered unacceptable. So this again highlights that chemo intensification of MRD positivity is probably not the way to go in managing patients with MRD positive disease. This was also historically shown by the high-risk protocol, the 0232, that intensified and extended the treatment of patients with MRD positivity by adding a second delayed intensification and a second interim maintenance. And what they've shown is that for this population that had slow early response based on MRD evaluation, at 3 years, the survival curves both for EFS and OS crossed, indicating that the intensification of therapy delayed the relapse but did not prevent the relapse, and the intensification of therapy associated with toxicity and more death events later on. So again, that's not the case. So can we do better? Should we be looking at end of induction or another time point? And this was the study of recent trials that tried to extrapolate data from clinical trials, either as a trial question or as a retrospective analysis of data. So the Children's Oncology group looked at this retrospectively. So from the high-risk protocol, the 232, they showed that if your end of induction is MRD positive, but your end of consolidation was MRD negative, your overall survival and event-free survival was 80% at 5 years, which is a reasonable outcome for this high-risk population. However, if your end of consolidation was positive, then your outcome was 39%, which tells you that this is probably the high-risk group that needs change of therapy. Is this the same for NCI standard risk? Again, this is a study by the Children's Oncology group that looked at the 0331 study, and it showed that patients that had end of induction MRD positivity and end of consolidation MRD positivity had a significantly higher cumulative risk of relapse compared if you were end of consolidation MRD negative. And you can see the figures here. The 4-year disease-free survival was 73% compared to 90% based on end of consolidation stratification. However, these end of consolidation MRD positive standard risk patients were salvageable. So the 4-year overall survival was above 90%, regardless of the end consolidation positivity or negativity in this patient population. So to summarize by NCI risk criteria, so if your end of induction is MRD positive, but your end of consolidation is negative and your standard risk, you had a DFS of above 90%. However, if your end of consolidation is positive, you had a 4-year DFS of 73%. However, your overall survival was above 90%, regardless of your MRD end of consolidation MRD status, if you are NCI standard risk. However, for the high risk, the end of consolidation MRD negative group had a reasonable outcome of approximately 79%. However, if you're end of consolidation positive and you're high risk, then you had a dismal outcome or an unfavorable outcome of 39%. And this is why the COG put a cautionary statement in their protocol that we caution our colleagues about intensifying NCI standard risk patients with end of consolidation positive MRD beyond high-risk backbone therapy without data that we will gather from 1731 and 1732. So this is the current approach summarized in one slide for the COG, where they are testing blinatumomab for MRD positivity at end of consolidation for standard risk population using 2 different methods of detection of MRD, the flow cytometry and the NGS method. For high-risk patients, they're testing inotuzumab for end of consolidation positivity. However, if your end of consolidation positivity exceeded the threshold for the protocol, they are testing CAR T cell as a mode of immunotherapy for this particular population in the upfront setting to treat these patients without transplant by introducing immunotherapy. But is NCI risk the only competing factor here? or do we have other competing factors? So the impact of genotype was actually well studied in the UCAL 2003 protocol that looked at the interaction between genotype-specific MRD and outcomes. And allow me just to explain this for 1 minute. If you look at the graph on the right side, you see that at the bottom of the graph, there's a scale of increasing relapse rate at 5 years after therapy. And this scale goes from 1% bright yellow to 45% the burgundy color. And when you look at all, and the density here on the y-axis represents the percentage of the population that are positive at this or negative at this particular threshold or level. So if you look at the top graph, which is all patients, more than 2,500 patients, you see that it's the 0.01% is a threshold that the risk of relapse is more or less the best threshold for the whole population. However, as you go above 0.1%, the color starts increasing, meaning the risk of relapse starts increasing. However, it doesn't reach the dark burgundy color. Now, if you look at the different genetic subtypes, that changes. First, in the ETV6 RUNX1, you see that the majority of the population are less than 0.01% in that particular genotype. And you don't see the dark colors at different levels. It's only when you reach levels at 5% that colors get dark. Similarly, the high hyperdiploidy, the colors start getting dark when you're close to 5%. However, when you start looking at the intermediate cytogenetic risk group as defined here at the bottom, the 119 and all other non-favorable or favorable diagnostics, you see that as the level goes above 0.01%, color starts changing very rapidly with the increasing level of MRD. In the high risk, the color starts changing even before the 0.01%. So the risk of relapse changes quickly with the increasing levels of MRD, even at lower levels than we use right now as cutoffs. For T-cell ALL, it's more tricky. You see that there is no burgundy here in the T-cell ALL, and the risk of relapse is higher when you go at 5% when tested at end of induction. So based on this method, they came up with this integrated risk group assignment where they looked at MRD and genotype, and they were able to define 3 different groups: a standard risk group, an intermediate risk group, and a high risk group that had different genetic groups and different thresholds for each group of MRD at end of induction. And you can see quickly that only the high risk group, which represents only 8% of the patient population, are those that had dismal EFS, high relapse risk, and dismal OS compared to the other groups. And when this group relapsed, only approximately 50% of these were high-risk relapses that are difficult to salvage. So this is an important study that concluded that although the risk of relapse was directly proportional to the MRD level within each genetic risk group, the absolute risk of relapse that was associated with a specific MRD level varied by genetic subtype and immunophenotype as shown in the T-cell ALL. And this is again to show you from a study that was done a decade ago from the BFM group that showed for T-cell ALL, depending on time point 1, which is end of induction, is probably not the right time point for T-cell ALL, as all patients that were negative at time point 2, which is end of consolidation, had a relapse risk that was not significantly different as shown in the left figure. However, if the time point 2, which is the end of consolidation in T-cell ALL, was positive, the risk of relapse increased incrementally with the level of MRD seen. So that concluded that MRD of 0.1% or more at time point 2 constitutes the most important predictive factor for relapse in T-cell ALL. So T-cell is different. So that, with that in mind, and with all these studies, a consensus statement was reached in the consortium that was published, statement that was published recently, showing that the general consensus that end of induction, end of consolidation is probably the right time point to choose. And in the COG, threshold of 1% or more, or residual extramedullary disease was the definition for end of consolidation failure. So to summarize, this was put nicely in the NCCN guidelines recently that showed when it comes for MRD positive post-induction, if you're not on a clinical trial, then you should give high-risk consolidation therapy. If you become MRD negative, then you should continue chemotherapy. You may consider transplant based on different variables that are mentioned in other studies. However, if you're MRD positive, then choosing a bridge to transplant, probably immunotherapy is a better bridge than chemotherapy based on the toxicity profiles, but it depends on what the history of the patient's treatment is, and then move to transplant after the patient becomes MRD negative. So in summary, what we know today is that MRD is prognostic. We know that MRD can detect a group of patients that can be treated with low intensity therapy with an almost definite cure, which are the standard risk favorable group. MRD kinetics are variable by leukemia genetic subtype, NCI risk, and immunophenotype. And patients who achieve post-consolidation MRD negative status do relatively well with chemotherapy alone. What we don't know today is would intensification of therapy by adding immunotherapy to chemotherapy backbone versus transplant and first remission in persistent MRD positive ALL would improve outcome. And that's the topic of the current running trials that are running today. Again, a summary from Dr. Steve Hunger in 2021 on how he would manage MRD refractory B-cell ALL. First thing to mention is that only a small percentage of patients will have MRD more than 1% at end of consolidation. So this will make it difficult to run clinical trials in this population if you don't have enough numbers. And they are extremely unlikely to be cured with standard cytotoxic chemotherapy. And the standard approach is to provide additional therapy, quote unquote, what that additional we don't know, to obtain an MRD negative CR and then undergo transplant, and more intensive chemotherapy, BFM high-risk blocks for those that become negative, or giving immunotherapy, whether it's off-shelf immunotherapy, i.e. available therapies that you can have access to easily, such as blinatumomab and inotuzumab, or CAR T cell that takes time to collect, putting a quote here that we may be considering collecting at end of induction if MRD is 1% as a plausible approach. And this is why MRD negativity is important, because if you're MRD positive pre-transplant, your hazard ratio is 4.77 for all events compared to that if you are MRD negative before transplant. So I conclude here is how I suggest we approach February. So I'll take this in with a grain of salt. So decision for MRD-based treatment assignment should be decided post-induction consolidation assessment. Patients who achieve end of consolidation MRD negative status should continue the high-risk chemotherapy backbone. Patients who have end of consolidation MRD more than 1% are considered failures and should be considered for immunotherapy followed by transplant versus CAR T cell. Patients with end of consolidation MRD between 0.01% and 1% should be discussed for best therapy based on the following criteria. If they are NCI standard risk, continue interim maintenance and reassess bone marrow for MRD and continue chemotherapy if negative. If they are NCI high risk, immunotherapy versus chemotherapy following a clinical trial versus immunotherapy transplant versus CAR T cell therapy. If cytogenetics is favorable or intermediate, continue interim maintenance 1 and reassess bone marrow for MRD. If it's unfavorable, then immunochemo following a trial versus immunotransplant versus CAR T cell therapy. And also the decision can be influenced by access to CAR T cell therapy and availability of a suitable donor. And should patients who have end of induction MRD positivity undergo collection for CAR T-cell therapy and plan for bone marrow surveillance is something that should be discussed in this population. And with that, I thank you very much.
Thank you, Prof. Wasil, for the wonderful talk. We really enjoyed it. And we'll take the questions, the QA sessions at the end. And now it's also a great pleasure to invite Dr. Abdullah Al-Jafri. He is our senior consultant, pediatric hematologist, oncologist, and transplanter at King Faisal Specialist Hospital in Riyadh. He's also associate professor at Al Faisal University. Dr. Abdullah will speak to us about his, well-known experience nationally and internationally about 25 experience of his transplant in thalassemia patients. So we will be happy to enjoy his talk, inshallah.
Assalamu alaikum. Thank you, Mohammed, for the introduction. I thank the organizers, the SSH and SSBMT, for organizing a live physical meeting. And I'm happy to meet friends and colleagues I haven't seen for a long time. And I'll take this opportunity to share with you our experience at King Faisal Specialist Hospital and stem cell transplantation in children with beta thalassemia major. Okay. So brief introduction. Beta thalassemia is basically a common problem in our country. And as you see, this is a normal hemoglobin, which is formed by 2 beta and 2 alpha globins that are held in a symmetrical fashion to give it its characteristic. And within that molecule is the heme that carries the oxygen. And there are 270 million hemoglobin molecules in each red blood cell. So the basic pathology in beta thalassemia, as I mentioned, you have 2 beta and 2 alpha, and if you lose the balance by not forming the beta globins, the alpha chains will precipitate and cause the injury and the formation of toxic hemochromes that precipitate and lead to the damaged red blood cells. Of course, this abnormality will lead to ineffective erythropoiesis and expansion of the bone marrow cavity, leading to all the consequences of the ineffective hematopoiesis with the extramedullary hematopoiesis and disfigurement of the bones and the rest of the pathology. This is what you see as an example of pronounced picture of a patient who is not properly managed with, as you can see, in the right side, the face with typical thalassemic faces with frontal buzzing, flattening, and prominent maxilla. You can see the hair on end appearance on the left side due to expansion of the bone marrow cavity. This is another example of a patient who's, again, poorly managed, and you can see the stunted growth and the clear physical abnormalities in the bones due to lack of proper transfusion. This is what this boy has: huge hepatosplenomegaly, basically as an attempt of the extramedullary sites to produce blood, but it's really this patient. Unfortunate, they couldn't make it to receive blood. They're receiving it once every 4 months or every 5 months. So what are the consequences of the beta thalassemia major? Of course, anemia is profound, and these children survive on blood. Unless you transfuse them, they'll develop all the consequences of disease. So iron overload, mostly due to the transfused blood that has, a lot of iron in it and increased iron absorption by the GI. The cardiac disease is a very important, complication, and mostly these patients unfortunately die in their teenage due to iron overload. Endocrinopathy, it can involve the pituitary, the thyroid, the pancreas, and the gonads, and these are common complications for those who are not well-chelated children. Bony disease is due to the extramedullary hematopoiesis, but endocrinopathy play a role in this pathology. The formation of the gallstones is understood because of the excessive hemolysis in these patients and the rapid red cell turnover. I mentioned that the extramedullary hematopoiesis with hepatosplenomegaly, but it can be quite pronounced with development of spinal masses that compress the spinal cord. Vascular disease in terms of leg ulcers, pulmonary hypertension, and stroke are expected and mostly seen in the thalassemia intermedia or in patients who are under transfused. So the standard therapy for beta thalassemia relies on effective transfusion. And when I say effective transfusion, that means not merely correcting the anemia, but transfusing sufficient blood to what we call hypertransfusion or super transfusion, keep the hemoglobin above 12, which is practically difficult to achieve in many children. So the maximum you can give them is transfusion every 3 weeks. And hope to maintain adequate hemoglobin. Safe products is something that is important. Iron chelation is of paramount importance, and this has to be initiated early after the blood transfusion. Usually we give it after 10 to 20 transfusion. We initiate chelation therapy because the precipitation of iron starts very early in life, and if neglected, it can lead to irreversible damage, especially in the endocrine organs. Proper monitoring implies that follow-up of these patients, and particularly for iron overload using the ferritin, but we know that the ferritin is not the best marker for iron overload. Therefore, either to do a liver biopsy, and nowadays we're using non-invasive method by MRI T2 star that you can do it for the liver and the heart, and even the pituitary gland as well, and the pancreas. Infection is something that you need to observe, especially in patients who are on regular transfusion. Endocrine, they need to be evaluated and followed by endocrine specialists because, the endocrine organs are affected. Others, of course, the side effects of the iron chelators, bones, ophthalmology, etc., etc. So what are the limitations of the standard therapy? We know that this is a chronic disease, and these patients, the aging patients, are developing complication, even those who are in chelation. Historically, the iron chelator was dysferal, and nowadays we have better iron chelator, but in many patients who are above the age of 40 complain of generalized pain or chronic pains, as Professor Saad have mentioned in her lecture yesterday. So this is a common problem that we see in patients who are transfused and on chelation. Liver cirrhosis. The effective chelation was found to be present only in 40% of these patients. Historically, we know dysferal is difficult, and the compliance with it was really bad. Adequate transfusion, as I mentioned, can be achieved on 12% of children, and the main reason is that the amount of blood given is the issue, and as well as the compliance of the parents to bring them in time. Health cost of therapy, basic transfusion, the new agents for chelation, the nursing, the other complications that happen due to disease and hospitalization, sometimes intensive care management. These are all significant costs of the standard therapy. Now, for working individuals, either the employee, they lose 2 days per month, or the students around 3 days per month school loss. The compliance of treatment, another problem, and the health-related quality of life. All of these are really significant sides of the standard therapy. Now I'll move to hematopoietic stem cell transplantation. and beta thalassemia. We know the concept is basically to replace the defective hematopoietic tissue with functioning or genetically normal cells that can, can lead to production of normal red blood cells and resolution of the anemia. As I mentioned, the anemia will be corrected, then transfusion will be stopped, and eventually you'll be able to chelate the excessive iron that is in these individuals, and they may lead a normal life. Correction of the consequences of diseases of physical disability and disfigurement of the bones. These are seen, especially in children who are treated early. All of these, changes are going to be resolved as they grow older. What are the favorable conditions for stem cell transplant? Of course, young patients. When I say young patients, usually within the pediatric age group, preferably if it can be done less than 4 years or preschool age. These are the best scenario to have these patients. Fully matched sibling or related donor, either father or the mother, is the standard of care, and these are the best candidates as donors to donate for their children. Absence of organ dysfunction, of course, which, on the other hand, that means these young patients do not have these end organ dysfunction like what you see in the adults. The major issue is the impact of iron overload on these patients. The Italy or the Italian experience, the classification of Pizarro 1, 2, 3, implying severity of disease with the absence or presence of hepatomegaly, liver cirrhosis, or fibrosis, and compliance with chelation or older age group, more than 14 years. All of these are adverse effects in terms of the outcome of transplant, and I'll show it to you in the Italian experience. The problems with stem cell transplant, it has complication, of course, and you have to discuss this with parents who are interested in proceeding with the transplant. Graft rejection is one of the commonest complications, especially in patients who are multiply transfused. Repeated transfusion, inadequate conditioning of these patients by chemotherapy, inadequate cell dose that is given to the patient, or the type of transplant. Ideally, the allogeneic fully matched donor is the best transplant. However, if you move to alternative donors, then you run into problems. Graft versus host disease is a major challenge for these patients, acute or chronic, and it can be a leading cause of death, as I will show you in our experience. Infections, of course, these patients are heavily immunosuppressed during the active transplant period and during the follow-up while they're in immunosuppressive therapy. You need to watch out for these patients. These patients are prone to viral infection, fungal infection, bacterial infection, and whenever you have patient post-transplant, you should put this in mind and treat them as immunocompromised. The transplant-related toxicity, due to the toxicity of the chemotherapy, they can develop pulmonary pneumonitis, liver dysfunction, veno-occlusive disease of the liver. You can have hemorrhagic cystitis and others. Every organ is susceptible to toxicity from the chemotherapy. Long-term complications are many, and the most important thing is the neurocognitive and growth and fertility, of course. Endocrine complications are expected, and they need to be followed after the transplant with the endocrine specialist. This is the Italian experience, which has a big number of patients included in it, over 20 years of follow-up. Our experience, I'll show you, over 25 years of follow-up. They had in their good risk group excellent survival of 93% and 91% thalassemia-free survival. As you can see, the rejection and the mortality is quite low. Similarly, you have in class 2, which is again still quite acceptable in this group. However, when it comes to class 3 or the severely iron overloaded or those with organ dysfunction, the survival becomes much less, of 79, and the disease-free survival of 58%. High rate of rejection of 30% and mortality close to 20%. So this is a major challenge, how to transplant older patients or those who are severely affected by thalassemia, by iron overload. This is the overall thalassemia-free survival in their study over 20 years, considering all risk groups. In our experience, we've transplanted 175 patients with median age of 5.1, and you can see the frequency on this curve. Most of them actually below the age of 7, and some of them, of course, beyond that. The males and females are almost equal, 50-50. And most of the donors are siblings, 86%. However, we have few parents who donated for their children. One antigen mismatch, we have 4 patients who had one antigen mismatch. The source of transplant was mostly bone marrow. However, we have 2 patients either have peripheral collection or combined peripheral collection as well as bone marrow. The stem cell dose was, the median was 7 million cells per kilo. And the conditioning regimens, in the old era, we used to use busulfan cyclophosphamide in almost quarter of the patient. Busulfan cyclophosphamide and ATG in 47%. And in the last era, we've been using Bucy and fludarabine in almost 1/3 of the patient. And I'll show you the outcome of each. The neutrophil recovery or the engraftment took around 17 days median, and the platelet recovery after the transplant, a median of 33 days to be transfusion independent. This is a summary of the outcome of the transplant in these patients. I don't know. So we have like 88%, 154 patients who are engrafted and transfusion free in green. Out of those, the 145 are engrafted and thalassemia free. 9 of them died, and we have 8 patients primary graft failure, which is 4.6%. All of them are transfusion independent, i.e. the majority of those who have primary graft failure, they recover their autologous or they have autonomous thalassemia recovery again. They became thalassemic again. Secondary failure was seen in 5.1%. 2 of them died and 7 are alive. So overall, the mortality rate is 8.6% in the whole cohort. The post-transplant thalassemia-free rate is 88%. The complication that we saw, we have, graft versus host, one of the major issues in 9% of the patients, skin, liver, and intestine. Veno-occlusive disease of the liver occurred in almost 10%, and this was self-limited together with the hemorrhagic cystitis. Almost 9%, again, is self-limited. The chronic GVHD, 4% of the patient developed it, and it impacted on survival, actually. So overall, the survival over 25 years, we have 92% survival. This is considering all severity stages from good, moderate, and severe. If you compare it with the Italian experience, I think we did better than it's thalassemia-free survival. There was 73%, in our experience, 83%. By conditioning regimens, the Bucy 74%, the thalassemia-free survival, the Bucy ATG 83%. And what are we using now? Bucy, fludarabine, almost 90% are event-free survival or thalassemia-free survival. These are some of the factors that impacted on, we looked at these to see whether they had impact on thalassemia-free survival. The age of the patients, whether less than 7 years or older 7 years, we draw a mark there whether older age group may impact adversely or not. It didn't look like it had significance, neither the donor gender, whether male or female, the donor age, whether less than 14 or older than 14, the relationship with their siblings or parents, all of these did not play a role. Very, very important and significant factor that we identified is that the day 100 donor cells whether they're less than 75% or more than 75%. It has high significance in 0.001. So those who had less than 25%, less than 75% at day 100, their chances of graft loss are high. Ferritin level as well, it didn't show a significant importance. These are we did STR on these patients of myeloid and lymphoid. As you can see, at day 100, we found 5-8% patients who are less than 25%, and 75% and above was seen in 87%. A similar value was seen in the lymphoid donor cells. Again, this is a representation of the patients in terms of the myeloid, 12.5% were less than 25%, and 75% were 98.3%. This is the impact of the myeloid cells at day 100 on thalassemia-free survival. As you can see, those who had less than 75% had the significantly low chance of making it to thalassemia-free survival compared to 75 or higher. This is in terms of the donor lymphoid cells, this is the same thing. As you can see, those who became transfusion independent, they had 75% or higher. Hepatic toxicity or iron overload in the liver, did it affect the outcome? It didn't look like it played a role. Even those who had severe iron overload in the liver, again, it didn't have an impact on survival. Cardiac cirrhosis, we saw it in one patient as mild. Again, it didn't play a role. This is the impact of acute graft versus host disease of 3 or 4 on overall survival. As you can see, there is significant impact on survival when you have severe acute graft versus host disease in these patients. Thalassemia-free survival, the same thing. It has significant impact on thalassemia-free survival. Chronic graft versus host disease on overall survival, you can see it played a role. Actually, it was one of the major causes of death in these patients. So what are the advances in thalassemia transplant? Improved preparative and conditioning regimens. These became, alhamdulillah, recently you have reduced toxicity regimen, the utilization of fludarabine, triosulfan, and thiotepa. You have alternative sources of stem cell transplant. I'm not going to talk about whether they are recommended or not, but they are available. You have the umbilical cord, and you have matched unrelated donor, and the haplo identical. You have improved high-risk GVHD preventive strategies by immune suppression and others. Expansion of the bone marrow transplant donor registry became available. And I'll end up by, the hematopoietic stem cell transplantation, the expert panel for the management of thalassemia. This was, published by SBMT Working Party recommendation in thalassemia that young thalassemia major patients with an available HLA identical sibling should be offered stem cell transplant as soon as possible before the development of iron overload and iron-related tissue damage. Transplant-related risk factors should be evaluated according to the Pizarro risk score. Nowadays, we're using the more non-invasive method of MRI T2-star. HLA genoidentical cord blood or BM bone marrow are equally effective. Peripheral stem cell transplant should be avoided as much as possible because it increases the risk of chronic GVHD. For the adults, it was suggested that it will be done under control trial unless these patients are well chelated and well managed in their centers. So with that, I'll finish. Pardon me, because of this time's sake, I will not go into the alternative therapy. I know people will ask about haploidentical and others, but it's negotiable. Thank you.
Thank you so much, Dr. Abdallah, for this excellent, elegant talk and for the excellent outcome.
and the huge experience. Thank you so much. I don't know whether if Dr. Muhammad is with us. Dr. Muhammad Al-Masri, is he online? Or is recorded?
Inshallah.
Excuse me,
Assalamu alaikum.
online?
Yes,
Can
sir.
we start? So it gives me great pleasure and honor to introduce Professor Muhammad Al-Masri. Dr. Muhammad, he is obtained his MBBCH and master degree from medical science and internal medicine at Ain al-Shams. Then he is also obtained MD and PhD degree of medicine from the same institution. Professor Al-Masri, he has internal medicine and hematology. He is a professor in the internal medicine and hematology department in Shams. And also he is acting a consultant and professor of hematology and bone marrow transplantation unit at Ain Shams University. Also, he has internal medicine and hematology consultant at the Cleopatra Hospital in Cairo. So he is certified as a consultant at the Saudi Arabia Health Authority. Dr. Al-Masri has been engaged in a number of research and multi-center phase 3 and phase 4 international drug trial. Professor Al-Masri, he will talk to us about the CML, chronic myeloid leukemia in 2022, time for treatment-free remission. So the stage for you, Dr. Muhammad.
Thank you very much, sir, for the presentation. I hope you can hear me. الصوت واضح؟
Yes. Wow.
Thank you very much. أتشرف بسم الله الرحمن الرحيم أتشرف بالدعوة الكريمة من الجمعيتين السعوديتين. I think this is one of the most impressive meeting that has been conducted during the past 2 years under cover of COVID, of course, but we would have wished to see you face to face, but I think we can do the job now. In the next few minutes, I'm going to discuss what's called the treatment-free remission. Is it a hope or a fiction? Improving the outcome for CML in the year 22. As you can see, chronic myeloid leukemia is a model disease in oncology. It has started in nearly 80 years by the definition of Virchow and Bennett when they introduced the definition of CML. Bedside and bench work together. It is a model, indeed a perfect model in oncology, where the disease has gone into many stages, starting from identification of translocation 922 to the introduction of the BCR-ABL and the definition of multiple diagnostic and therapeutic options that has started with the introduction first generation TKI, second generation TKI, drugs beyond, and then after many years we got greedy and we introduced the concept of can we start treatment, can we stop treatment, and this was the first evidence by the TFR in the year 2011, where the first STEM study showed that we can indeed stop treatment. And not only that, this was augmented by the Eurosky study, where the reintroduction of treatment-free remission was even better and better. So, to go to our introduction, chronic myeloid leukemia used to have a median survival of 4 to 5 years only, but nowadays those patients nearly have a normal life expectancy. Not only that, but the potential for cure has also been introduced with the aggression of treatment. So nowadays, the goal of treatment-free remission is an attractive option, not only to the physician, but also to the patient. And here are the suggestions that I'm going to make. Let us first consider what is the disease control. Is it best overall survival, a return to normal life expectancy in the presence of ongoing treatment, or what I prefer to call operational cure, where there is no evidence of the disease in the absence of treatment, or what's called treatment-free remission. So this is a sort of a cure by itself. Going to the magnitude of the CML, you are going to notice 3 things. The first is the toxicity, the comorbidity, as well as the accumulation of patients. In the German CML study group experience, you will notice that by time, many patients are accumulating. If you compare the survival of patients or the prevalence of CML in the year 20 to 2012, then later on, you will find that so many patients started to survive more. They started to gain more expectancy in life, and this has led to the accumulation of many patients. Not only that, but the expected prevalence of CML in Europe by the year 2050 will be triple what is going on now. Now, the increase in prevalence is mainly due to better understanding and better treatment. Even some have suggested that this will be the global, what's called the CML epidemic, where by the year of 2027, we will have an accumulation of patients that has been reported to be 20,000 additional cases surviving per year. This accumulation will lead to a magnitude on the finance of the treatment of those patients, as well as the expense of the treatment that is increasing by day. So treatment now have to be considered with a treatment-free remission, eradication of leukemic cell, tolerability, resistance, and disease progression has to be considered before we started to answer the question. Not only that, but to add to the problem, 50% of patients with CML have at least a comorbidity at diagnosis. This comorbidity is even as important as the disease itself. So in one study, you will find that the influence of comorbidity was tested by the Council Comorbidity Index, and it was even more important than the magnitude of the CML itself. So another reason, that's why we have to consider stopping the treatment. Many studies has been included to try to consider the treatment-free remission and for the treatment reinitiation. The ESMO, the NCC guideline, and even some cooperative group have considered this, and they have different criteria or characteristic, whether more than 5 years, 3 years, or less than 3 years for those patients who has achieved a major molecular response. Monitoring also is different among different groups. Some for the ESMO is a 6 monthly for those patients who have achieved TFR, or the NCC guideline a yearly follow-up, and some recommended other. However, this should be considered. STEM study was the first study to be conducted in the European Society, where this appeared that molecular recurrence plateaued about 18 months after stopping treatment. So those patients who have achieved a treatment-free remission and have achieved what's called a near clinical cure, if they survive the first 12 to 18 months, most likely they will maintain themselves as a treatment-free patient or acute patient. This has been confirmed by the EuroSky study, where the similar number of patients was also reported by them. A rapid glimpse to the same study. This is a prospective, non-randomized, multi-center study that was conducted and was followed up by the STEM 1, 2, and the extension of this STEM study. STEM 1, the first proof of concept of the treatment-free remission, was conducted in a 100 patients, and there was a central laboratory assessment of those patients. In this study, the cumulative incidence of molecular recurrence after imatinib discontinuation was nearly 61%. But remember again, after 18 months, those patients who maintained a negative disease or a fresh disease state are considered to maintain this plateau form, and they were followed for a period up to 96 months. So the concept of achieving a near cure to those patients was clear-cut and was evidenced. The EuroSky study, another major study, has shown that molecular relapse-free survival for 373 patients was nearly 50%. Death in remission was 1%, which is acceptable compared to those patients who were maintained on the same kind of treatment. So 50% chance for our patient to achieve a near complete cure or treatment-free cure. Cortez and colleague in the MD Anderson group have proposed that treatment-free remission is an option, and they put the criteria that will define which patient will definitely get better. Among the studied so-called score, the PR transcript type and the optimal type, the most important of them all was the duration and the depth of response. For example, a duration of a TKI treatment of more than 8 years with a deep molecular response, as well as a duration of major molecular response of more than 2 years, those patients most likely will get benefit from stopping their treatment. And there is still a chance for relapse. But what's more important is that those who achieve another deep molecular response once treatment has been reinitiated is very high, and the patient do not develop any resistance to the medication. So if you take this risk of stopping treatment, don't worry, because once you reinitiate the treatment, if the patient relapses, he will get the same response and will not lose any of the patient. So some of the studies that has made a landmark for the treatment-free remission for the first line treatment by the Notalib has shown that in the STEM 1, STEM 2, Twister, and the STEM, as well as the KID study, those patients, 50% of patients will benefit from stopping the treatment. Some of those patients has been followed up for a period of 81 months, and still they are doing well, carrying on a normal life. So our objective before treatment-free remission is considered is to have a deeper molecular response by the first step for the treatment of those patients, and the longer the duration as well as the deeper the response, the better the outcome of the treatment-free remission of those patients. Possible criteria for the selection will go to the green, yellow, and red famous marks, where you can define your patient. In the red group, those patients only has to be followed up in a clinical trial. Yellow patient, you may or may not consider stopping the treatment, while those patients who are fitting the criteria of the green color should go for the treatment-free remission with a high probability of being able to stop the treatment for good. Another issue is the patient perspective. Patient is always worried about 30 things. For him, toxicity, side effect, better information, pregnancy, and the cost of the treatment is the patient perspective, and this has to be respected in that. Of most important, that nearly 44% of our patients will have some fear. I did not feel fearful or anxious when I stopped the treatment, but I am fearful and anxious because continuous treatment may cause me a lot of side effects and may interrupt the treatment of life. So to consider treatment-free remission in CML patient, we're going to go for two issues. The first is the first line and the second line treatment. For those patients who are in the first line, Nature has published the European Leukemia Net 2020 recommendation for the treatment of chronic myeloid leukemia, specifically when to stop treatment. This is defined and mainly important to consider that the BCR-ABL less than 0.01 or MR4 and better MR 4.5 should be our target before considering stopping treatment for those patients. And you have to remember that in the CML study, the NS study, the DASN study, they all have a different outcome for a patient who may receive first or second line. So keeping in mind that MR4 or MR 4.5 and even better, the recently introduced MR6 should be our surrogate for those patients who are going to be treated. The ELN recommendation have put 3 groups: mandatory, minimal, and optimal. Optimal, again, is a duration of TKI therapy of more than 5 years, duration of a deep molecular response of more than 3 years if the patient achieved MR4, or for 2 years if the patient did achieve a deep molecular response of more than 2 years. This is sufficient enough to consider the treatment. Here in red, the arrows will show that the sustained deep molecular response can be achieved in two situations: for a first-line treatment, as well as for those patients who failed to achieve a first-line treatment with first-line therapy, then he went for nilotinib or second-line TKI. Again, he may have the chance of a TFR for the second phase, and again, the patient may be able to stop treatment for the second chance to them. Diagnosis of CML deep molecular response, and TFR attempt will give you a fixed 50% chance of succession. That's to say, nearly 50 to 60% of our patients may stop successfully the TKI therapy. They may carry on their life, particularly for a female who may need pregnancy or a young patient who may need to carry on life. Remember that the milestone in CML first-line therapy has been quite respected by the ELN, NCCN guideline, as well as the ESMO, and the optimal response, the warning and the failure is now clear and very important to be recognized that the achievement of our treatment can even get better and better by time. So by time, we may increase the number of 50% those who may stop the treatment, and this can be achieved by doing different studies. This has been reported in the Ernst stop, in the ISAV, and the DAD study, as well as the D-stop, and the extension of the EuroSky, as well as the DAS-free study. Those studies have put a clear guidance that treatment-free success may increase from 38% to up to 57% in the D-stop study. So nearly 60% of our patients, or even 61% in the STEM study, patient has been successfully followed up for a long duration of time when they have a treatment-free remission success. The Ernst study has shown that the cumulative incidence of MR 4.5 at the time and the first MR 4.5 is also important and crucial. So having a deep and sustained rapid response by using nilotinib as a second line, which has been shown to be better than those patients who are maintained on imatinib. So the long-term treatment-free remission in patients with CML in a chronic phase following frontline nilotinib, again second line use as the front line, has given better outcome of those patients as was tested by the Ernst Freedom study. The cumulative rate of MR 4.5 regained in nilotinib, 50% of my patients did achieve a treatment-free remission in as early as 12 months of therapy. Again, the conclusion was that of the patient who reinitiated treatment, who relapsed following loss of MMR in the main TFR phase, 99% of them regained MMR and MR 4.5 during the treatment reinitiation phase. So we did not lose anything if we try the TFR for those patients. This finding support the safety of TFR following frontline nilotinib with no disease progression or death attributed to CML stoppage of treatment. Although the data suggests that more patients treated with frontline, second line may benefit more from TFR than those who are treated by first line treatment. The decision study also showed that when you use the zatinib as upfront compared to imatinib, you are likely to have a better TFR for those patients, provided that those patients have a cumulative rate of MR 4.5 that is better when you use a second line compared to first line. This also has been reported by the pozotinib compared to imatinib in the phase 3 before study, where TFR was amenable by the use of pozotinib for a patient who have failed treatment with imatinib, and the outcome of those patients is by far better, and the cumulative incidence of MR 4.5 achieved was by far better. This is the comparison between the both studies. Another issue that is important to the patient is the intolerable side effect, particularly the QT prolongation, hypertension, the elevation in liver enzyme, thrombocytopenia, and some patients may develop fluid retention that is troublesome to them. So the second issue to suggest why should we stop treatment is, from the patient view, is the side effect of the treatment of those patients. The adverse event has been reported for each TKI, and each one of them is quite different, from facial edema to pleural effusion to viral reactivation and to drug-drug interaction. So the patient perspective on TKI treatment and treatment-free remission has also been studied, and here the evaluation of the quality of life of patient who has been reported by the new instrument show that those patients feel better emotionally, physically, socially, as well as to other parameters if they stop the treatment, not to mention again the accessibility to pregnancy and the availability of the regaining fertility. This relationship with the MRR and patient were quite disappointing for the physician. For example, molecular response has the most robust relationship with the emotional well-being. Molecular response has the weakest relationship with the physical well-being. A patient may have a deep molecular response, but his quality of life as well as the social well-being are not that much better for him. So there is a discrepancy between achieving a major molecular response and the quality of life or the well-being of our patient. Again, this is an indication. This was studied in a total of 1,000 patients in 68 countries. Some of them were in the Middle East, and some of them are Arabic-speaking country. And the unmet need for those patients was quite considered to take the advantage of, I need to stop treatment, doctor. This has been shown that nearly 50% of the patients choose to stop treatment because of the side effect or the fear of side effect, and cost was considered by nearly 15%, and the need of pregnancy was by far for female compared to male, 3 times for the female patient tended to stop this treatment. CML patient perspective impact of the side effect also has been a major problem for those patients. This has led us to tackle the Arab Leukemia Network. This is an organization that has been postponed, and we shared our activity in the ASH as well as in the European Leukemia Net, where we have studied most of our patients, and we have recruited nearly 1,300 patients who were adherence, compliance, as well as stopping of the treatment in what's called the ASH-safe stop. We have advocated the ELN guideline, and we stopped treatment. So those patients who did stop treatment in the Middle East did show similar result to that were observed in Germany, France, as well as in Italy. And the final hope message is that try to do a treatment-free remission to your patient, save the cost of the treatment, give the patient a better life to carry on a normal life. Green, yellow, and red should be your guide to treat the patient and when to stop that treatment. And I thank you very much.
Thank you. Thank you so much, Professor Muhammad. Thank you. That was an excellent talk. So please, can you wait with us? So we'll open the floor for the question. We have only 5 minutes, please. Try to cut the time.
Waiting.
Do you have any question?
Assalamu alaikum, Ali Gregory, Jeddah. Thank you so much for this amazing talks. My question to Dr. Abdullah Jifri, excellent long-term result. And I think you left the haplo identical and the other alternative for the Q&A questions. So could you comment on that, especially for a disparate family that did not have a fully matched donor, and their child is struggling with the transfusion and may have allo antibodies and so on and so forth. What's your experience, how you take to, and what the expected result if you have been seen or at least seen in other centers?
Thank you. This is an expected question. I'm sure that people, not everybody has a chance to have a fully matched donor. However, one should consider the complications of the alternative transplant, especially if you consider haplo identical. I think match unrelated donor possibility is there and it's internationally accepted. The only thing is that the complication of graft versus host disease is really worrisome in these patients. So again, I mean, in our center, we haven't done patients with match unrelated or haplo. Now, haplo is still not acceptable as a standard therapy, but in clinical trial basis, it can be done. Now, there are some reports from Thai groups, they've reported, extremely excellent results. I don't know whether we can replicate it here because our experience with haplo is still are not that safe or that can be offered to a benign condition such as thalassemia. We see horrendous complication after haplo transplant, and still not the standard of care. However, if somebody wants to explore doing it, we started doing haplo for selected patients of sickle cell as investigational trial, not as a standard of care. Now, for MUD, I think it's a possibility, but I think the graft versus host disease is a problem. Maybe one could look into doing a post-Cy sort of conditioning regimen to avoid this complication. It is possible to do it in that way. But again, I mean, the consortium doesn't, project alternative transplants unless you have fully matched, genetically matched donor.
Okay. Any other question?
Question, Dr. Abdullah, Dr. Wasil. I will start with Dr. Abdullah about the fascinating results. So I'm very interested about the mixed chimerism results, which reflects the 75% as a cut limit in your cohort. In general, just an advice for people who deal with transplant patients, and especially the ones with a lower chimerism in general. In terms of strategy to prepare the patients, do you consider preconditioning nowadays furthermore, like preconditioning hydroxyurea as a thioprine? Or on the other end, if you deal with chimerism, then you're expected to increase immunosuppression and prolong it for a longer time. Are these strategies, you think, does it show any difference or in your experience?
I don't know about I agree with you. You mean the preparation before initiating the conditioning?
Yes.
And the aim of shrinking the hematopoietic tissue, so you can decrease the incidence of rejection. That's something that can be done, and I think it's a good way, and it's done in several centers. In our center, we haven't explored, although it is recommended in severely or advanced, iron overload patients. It certainly will impact. However, you cannot still predict whether immune suppression will decide whether the patient is likely to reject or not. Again, this is really a very delicate thing, whether to intensify the conditioning, the immune suppression, or to decrease it in the hope that you may revive the graft. But in our experience, it didn't work really. I mean, if the patient is doomed to reject, they're going to reject no matter what. Same thing if patients are done as a, if it's early graft rejection, boosting the graft again, it didn't really help. Giving immunosuppression and boosting with stem cells, it didn't really help in these patients. I'm talking about several similar conditions like aplastic anemia, not necessarily for thalassemia. But yeah, I mean, the point of you need to intensify your preparation before, I think it may help a great deal.
A quick question to Prof. Wasil, just the bottom line, your experience is very important. Standard risk NCI with persistent MRD, end of consolidation. What is, I know you mentioned it at the end in the late of the slide, but what are you doing in terms of immunotherapy, or and then once you put the patient in remission, you just continue without transplant? So transplant or not to transplant?
Yeah, so the recommendation, or what I would recommend, is that such patients, depends also on the level of the MRD, but if it's end of consolidation is below 1% and standard risk without any issues related to genetics, it's not upscaled because of his genetic or her genetics background, then I would recommend to continue interim maintenance with the high-dose methotrexate and repeat after that cycle. If MRD negative, I would continue on chemotherapy only. If it's MRD positive at that stage, The discussion is whether you would align with a transplant immunotherapy and then a transplant at the end of the therapy. It's a hard one, but weighing the risk and benefit. If you have access to CAR T cell therapy, that may be something you would consider without using CAR T cell as a bridge to transplant, but using CAR T cell and monitoring the patient afterwards. All these are not backed up with evidence. So these are case-by-case discussions that you would treat one patient different than the other based on the facts that you have for that particular patient. And that's personalized medicine right now. So I think when it comes to MRD right now, you cannot give one prescription or approach to all, but you have to take different considerations in each case.
Okay. Yes. Okay, short answer, please. تفضل. في صوت ما في صوت.
Thank you, Dr. Wasser, for a nice presentation for MRD update. And really, I have a question about persistent MRD patient with a high-risk patient, even after immunotherapy and the prognosis for going for transplant. What do you have experience about this patient?
So you have a high-risk patient that is persistently positive at end of consolidation.
Yes.
So for high-risk patients, it's somewhat easier because for those patients, you can justify transplant because their outcome with positivity after end of consolidation in the COG hands is like 39% event-free survival. So these patients are probably best bridge to transplant. So you can use whatever bridge you can, or a discussion with CAR T cell approach if there is access to CAR T cell. So these are two different approaches. If you have access and you can convince the CAR T cell center to take this kind of patient, then go ahead. If not, I would give immunotherapy and transplant once the donor is set up and your transplant is ready to go.
Okay, thank you, Dr. Wasser and Dr. Abdallah. My question for Dr. Wasser regarding infantile leukemia, the MRD. As we know, this is infantile leukemia is different biological distinct entity with a very poor outcome and usually associated with translocation 11q23. What do you think about the best technical method for assess for MRD in the infantile leukemia? Do you think this is the standard one by flow cytometry, or do you think there's other one because outcome is very poor?
Yeah, it's an important question. Thank you for the question. I did not include infant in this talk because of the duration of the talk. I tried not to include Philadelphia, but it was important. So for infant leukemia, MRD measurement, I think it's important first to know what's validated in your center to make sure that you choose the right MRD measurement for that particular case. For the North American approach, flow is still the way to go. For the European approach, they're using PCRs. And the PCR is not necessarily KMT2A PCR, it's the immunoglobulin T-cell rearrangement PCRs. And MRD positivity approach in infant ALL is somewhat different. I'm sure you know about the results of the Interfront study where MRD positivity stratifying to AML type therapy produced better outcomes than non-AML type blocks of therapy. So the approach to infant is a bit different. I think infant ALL is one of those that the whole approach to management of infant ALL is changing, whether chemo is the right approach to go or we should start incorporating immunotherapies upfront. And I think that is the question of current trials that are being discussed. But for now, I think MRD by flow is used by most. I know some centers are more comfortable with PCRs.
So the last question for Professor Masri, this is me, I will ask you, how are you going to approach a patient, he's 20 years,
who have CML. With one, he is 60 years in the term of treatment and stopping the treatment. Did you hear the question?
Again, please.
If you have a patient 20 years old, he has CML, and you have another patient, he's 60 years CML, how are you going to approach to his treatment, and when you're going to stop the treatment?
Yeah, it's a very important question, and I think it has been addressed in the recently introduced ELN guideline, and we participated in this guideline with Professor Qari. We have two distinct entities. In the Middle East, we have a very young patient who tends to be aggressive disease, and the possibility of transforming to acute leukemia or Philadelphia positive ALL is high, and those patients need to be treated by second line aggressive treatment as much as you can, and even combine multiple modalities of treatment, which has been the trend nowadays, and make sure that those patients, whether he's going for transplantation or not, but be as aggressive as you can, have the deepest and the most rapid response possible. While for an elderly patient, and treatment-free remission here is going to be a little bit difficult for the young patient, but we have to consider it if the patient maintains the criteria mentioned before, the MR 4.5, deep molecular response as deep as possible, even if you can reach up to MR 6 is good. Give the patient the chance so that you may stop treatment, and particularly for a female going for pregnancy. While an elderly patient, first line would be the option of treatment for them, and they usually tend to do better than the younger patient group. So go for the treatment for remission for both, but be very careful for the young patient to have the deepest possible response to them, so that we will not miss those patients into a transformation state.
Okay, thank you so much. So we'll conclude this session. In behalf of you, I would like to thank our eminent speaker, Professor Wasser, Professor Jeffrey, and Professor Al-Masri, and thank you for all the audience. And because the time, so I will call Dr. Azza to start this session number 4. Dr. Azza, she is consultant pediatric hematology oncology and bone marrow transplantation at Prince Sultan Military Medical City. Thank you so much.
Are we going to finish the stations, doctor? The entire? Okay. Yeah. They will come.
محسن الألفي.
Yeah, they're supposed to be here. The moderator, I'll look for them. Dr. Najla, huh?
And Najla, she is the speaker.
Oh, okay. So you're one of the moderator, doc?
I have محسن الألفي with me.
I cannot find the other moderator for the next session. He's a moderator. Yeah, because this is a moderator. Go ahead. Go ahead, doctor.
Assalamu alaikum wa rahmatullah. Welcome to the last session in this conference, but I'm sure it's going to be a very attractive session. So please stay with us. So it gives me a pleasure to introduce the coming speaker, Dr. Najla Al-Imam. She is consultant pediatric hematology oncology at Prince Noura Oncology Center at King Abdulaziz Medical City. Dr. Najla, she is graduated from Al Khartoum University, and she did her MRCB CH at United Kingdom, as well her hematology oncology fellowship. Dr. Najla, she is going to give a talk about the germline genetic variation in acute lymphoblastic leukemia. Please, Dr. Najla, the floor yours.
Good afternoon. I would like first to thank the organizer committee for the great invitation and for the opportunity to discuss the germline genetic variation in acute lymphoblastic leukemia. I have nothing to disclose. These are the outlines of my presentation. I will start with a small introduction. This will be followed by a quick review of the genetic variation that predispose patient to develop acute lymphoblastic leukemia and the variants that affect the treatment outcome. We will take this information and go to the second part, which will discuss the clinical application of this data to come up with recommendation and conclusion. So as we know, acute lymphoblastic leukemia is the most common cancer in children. It constitutes 25% of the cases. And we know over the years, the outcome of acute lymphoblastic leukemia in children improved dramatically. And now more than almost 90% of the patients are long-term survival. One of the reasons behind this great improvement in the outcome is related to the discovery of genetic abnormality in the malignant cell that has been linked to risk stratification and led to improve in the outcome. Despite this great improvement, there are still a lot of questions that had been remained unanswered. One of these questions is the cause of the disease, the mode of inheritance, and if there is inheritant risk factor that predispose to acute lymphoblastic leukemia, and the question that why different patients with the same clinical characteristic have different response and different spectrum of toxicity. So with the recent advancement in the genetic diagnostic testing, including whole genomic sequencing and genomic-wide association study, beside the family study, a lot of discovery has been evolving. It was discovered that 10% of children with acute with cancer in general, they have a hereditary base, and in acute lymphoblastic leukemia, this percentage is 3 to 4%. Besides that, it was found that there are genetic base and the hereditary base for treatment response and toxicity to some chemotherapy. So we'll start with the genetic predisposition to acute lymphoblastic leukemia. In the literature, there are a lot of classification of genetic predisposition to ALL. However, I found that the most useful and easy to remember is to divide this into 3 groups. The first group that include the genetic syndrome that known to be associated with acute lymphoblastic leukemia, and this namely Down syndrome, the syndrome that associated with bone marrow failure, and the chromosomal breakage syndrome. The other group that has been discovered to be very common among patients with acute lymphoblastic leukemia, this common allele has been linked to germline mutation in acute lymphoblastic leukemia. However, their effect is small as a predisposition syndrome. And the last group is the rare germline variant, although they are rare, and they were discovered in patients who have family history of leukemia, but they have a large effect as a predisposition and risk factor for ALL. Sorry, it's not moving. So these are the genetic factor I'm going to talk about. We'll talk about the Lee-Fromini syndrome that is associated with TP53 mutation, the RUNX1 mutation, IKZF1, BAX5, and ETV6 RUNX, just for the sake of the time. So if we talk about the base, the truly time where the thinking that acute lymphoblastic leukemia have hereditary base started when we discovered that TP53 is the cause of what called Lee-Fromini syndrome. Back in the 50s, there has a lot of reports that reported kinders with multiple close relatives affected by the cancer. And in the 1969, Lee and Fromini described the syndrome that there is cancer in the family. However, it was in 1990 when TP53 was identified as the causative gene. This is a report from COG that the targeted sequence of TP53 in 3,800 patients treated in 2 clinical trials. They were trying to identify the features. They are trying to identify the feature of patient who's harboring this genetic mutation and their outcome. So they found that there are a lot of variants of TP53 mutation. They identified 49 variants. However, out of them, 22 variants only found to be pathogenic. The other important finding that they reported that the older age and hypodiploidy is the most important clinical characteristic of patient who's harboring TP53 mutation. And they found that those patients here in the how can I do it, arrow? Sorry. Okay, so here in the upper left graph, you can see that the comparison in the outcome between the patient who's harboring pathogenic mutant TP53 compared to the patient who has harboring the TP53 of unknown significance. And you can see that the graph is totally separated. They also looked to the outcome of those patients, and they found in the long term, they have a very high risk of second malignant neoplasm. This is in the other graph. So out of this study, they concluded that preemptive surveillance of second cancer is very important for patients who is reported to have TP53 mutation. And they question if hematopoietic stem cell transplant is the right answer for them, especially that they are reported to have a very high risk of second malignant neoplasm, especially the TBI-based preparative regimen. So this opened the floor for research for non-genotoxic therapeutic strategy for patient who's having TP53 mutation. The other important genetic mutation that predisposed to acute lymphoblastic leukemia is the BAX5. BAX5 is one of the family of transcription factor. It's very highly expressing beta cell lineage. It's very important in maintaining identity and function of mature B cell, and it's very commonly mutated in somatic cells in acute lymphoblastic leukemia. It reached to 30%. In 2013 was the first time when a member of 3 families reported to have recurrent acute lymphoblastic leukemia among several members of the family, and they are 3 unrelated, but the genetic testing isolated the same germline mutation of PAX5. However, the same mutation has been identified in the siblings of this family, but some of them didn't develop leukemia. That signify that this PAX genetic abnormality has incomplete penetrance. In the preclinical data in the mice, it was found that if they correct the abnormality in the PAX5 and the amount is corrected, the mice don't develop leukemia. And this raises the question of sibling screening and pre-implantation genetic diagnostic for patient and family who's harboring germline mutation of PAX5, and it opened the floor for therapeutic targeted therapy that restore PAX5. The third genetic variation is the ETV6 variant in ALL. The ATV6, it encodes for family of transcription receptors. They are essential in establishing hematopoiesis and maintaining the survival of hematopoietic stem cells. The fusion is very common in acute lymphoblastic leukemia. It's the most common actually fusion abnormality somatically found in acute lymphoblastic leukemia. It has 50 translocation with 30 partner, and characteristically, patients harboring this mutation somatically have very good outcome. There is a report that come out in 2015, and this is the first time to discover that PAX has a relation to predisposition to acute lymphoblastic leukemia. And they found in this 8 unrelated family that the mode of transmission is autosomal dominant. And those family, they have both thrombocytopenia and high MCV, and they found to have cases of acute lymphoblastic leukemia. After that, a large study that was done also by the COG included 4,400 patients with acute lymphoblastic leukemia. They did sequencing of the ETV6 among the patient, and they discovered that 1% of the ALL cases, they have a germline mutation of ETV6. Characteristically, the patient who's harboring this genetic mutation is having hyperdiploidy in their somatic mutation. There is another study, it's very interesting, that was done among the patient with familiar or inherited thrombocytopenia of unknown origin. And in this study, they identified several patients with ETV6 related thrombocytopenia. 4 of them developed acute lymphoblastic leukemia. And this suggested that, this study, the author suggested that we should screen any patient for ETV6 ranks if they had autosomal dominant related thrombocytopenia with normal platelet size, because they are at risk of developing acute lymphoblastic leukemia. So this is the recommendation that comes from this small number of patients. The last one is the AKZF1. As we know, it's widely expressed among cells of patient hematopoietic, of cells of the hematopoietic system. It's very essential for specification of lymphoid lineage. So somatically, it's mutated in a number of patients, more in adult rather than pediatric. And those patients characteristically, they harbor Philadelphia chromosome positive or Philadelphia-like chromosome. And they characteristically, they have poor response to therapy. In 2017, this was the first time to report that IKZF is related to germline predisposition. When they identify individual with common variable immune deficiency and reported to have leukemia. At the same time, before they develop leukemia, they reported that they have abnormality in the hematopoietic stem cells. In 2018, they identify a family who's carrying germline mutation in IKZF, and 2 of them develop leukemia. So to more characterize that, the COG and the St. Jude, they have a combined study that they look to 4,900 patients treated in different clinical trials. And out of that, they discovered that there is 27 variants among those patients, and most of them, they have lymphopenia, and maybe they have underlying immune deficiency. So these are the summary of the gene that has been discovered to link to germline mutation, which is TP53. And characteristically, the associated leukemia is having usually having hypodiploidy. The BAX5 linked to hyperdiploidy acute lymphoblastic leukemia. The ETB6 ranks, most of the somatic mutation detected is dicentric isochromosome 9, and the IKZF, of course, BCR-APL-like acute lymphoblastic leukemia. So we'll go to the other part, which is the germline genetic variation in treatment outcome. A lot of work has been done trying to identify the tumor-related factor and host-related factor that affect the different response and different toxicity among patients with acute lymphoblastic leukemia. In 2009, this was the first genomic-wide associated study that looked to ALL treatment response. It was reported as a combined from the St. Jude and the COG, and they identified a lot of single nucleotide polymorphism that was linked to the pharmacokinetic and pharmacodynamic of anti-leukemic agents. A lot of work has been done and reported regarding the myelosuppression during maintenance chemotherapy. And this was found to have a genetic base and inherited base. And now it's used in the clinical practice to decide the starting dose of 6 mercaptopurine during maintenance chemotherapy. It was being linked directly to the MRD clearance and relapse risk. Another important drug is the glucosteroid-induced osteonecrosis. It's a common problem, especially in adolescent and adult. And there is a lot of work has been reported about the connection between osteonecrosis and familiar thrombophilia, hypofibrinolysis, and a lot of gene has been identified. However, this didn't translate into clinical practice. Another important problem that face patients with acute lymphoblastic leukemia during their therapy is the asparaginase-induced allergy and pancreatitis. St. Jude has identified in their study that there is single nucleotide polymorphism that involves some genes that lead to increased risk of asparaginase-related allergy. And this has been linked in the literature to bronchial asthma and risk of atopy. The final thing that has a lot of work done is the MTX and the risk of increasing mucositis and neurotoxicity. There are a lot of genes that has been reported, including MTHFR. However, over the years, it was discovered that the most important factor is the clearance of the medication. So the use of genetic variation in MTX didn't come to the clinical practice yet. So so far, what we know that few germline genomic association have been required level of evidence on clinical utility to permit routine use as a clinical test. We're expecting that with the improvement of the diagnostic testing that new data will emerge and ALL-specific somatic and genetic alteration to predict each patient risk will come into clinical practice so soon. That will lead to personalization of treatment regimen and optimizing the anti-leukemic effect in patients with high-risk acute lymphoblastic leukemia. The challenges in this study is to distinguish if any discovered new variant is really related to risk of predisposition or it is just by incidental finding. And this to be confirmed, it needs to have a cohort of cancer patients as well as a control group. this will be faced with another challenge that different ethnicity can have can lead to difficulty in interpretation. Another challenge is the determination of functional relevance of any identified germline variant and to understand the impact of germline variant on clinical phenotype. Okay, we're about to conclude. So when should we screen for germline predisposition? We know there is a clear guidelines in the literature when to test for germline mutation if there is personal or a family history of cancer. However, there is no clear guidelines when to test if there is for patient with acute lymphoblastic leukemia if they have this reported somatic mutation. And there is an expert review that's published in 2019 that we recommend if the allele frequency is 30 to 50% in such somatic mutation, we have to go for germline testing. This recommendation can easily be challenged. Why? Because condition that reported association is just recently described. And because in acute lymphoblastic leukemia, the rapidity of disease is very rapid. So how frequent shall we test? And if the surveillance is going to provide any medical relevant benefit. So the recommendation can be easily just to teach the parents and parents about the symptoms, and this might be enough above testing for genetic. So to conclude, recent family-based large-scale high-throughput sequencing study have uncovered several novel genetic conditions predisposed to acute lymphoblastic leukemia. The gene associated with these ALL predisposing conditions are often the same as what's reported in the somatic blast. The gene status of leukemic blast can provide clue to underlying predisposition condition. Knowledge of underlying ALL predisposition condition might inform leukemia treatment. Continuous effort are warranted better define spectrum of penetrance to known ALL predisposition condition. Thank you.
Thanks, Dr. Najra. And it gives me a great pleasure to introduce our colleague, Dr. Badr Al-Hayani. He is a consultant pediatric hematology oncology at King Abdulaziz Hospital. Dr. Al-Hayani, he has his fellowship at Ottawa, Canada, and he has a lot of work and research focused in pediatric hemostasis thrombosis. And he is going to give us talk about the DOACs used in pediatric patient. Please, Dr. Badr. I think Professor Mahsen Al-Alfi, he is with us online and from Egypt, and he is going to introduce the last speaker, Dr. Amal Bashlawi.
It is my honor to introduce Professor El-Bashlawi. Professor El-Bashlawi is an emerite professor at Cairo University, Abu Rish. Professor El-Bashlawi graduated a few decades ago from Cairo University, and she is the founder of the Pediatric Hematology and BMT in Cairo University. She is the president of two prestigious societies in Egypt, the Thalassemia.
Thank you for the committee for inviting me talking about
Federation,
DOAC and pediatric.
Egyptian Federation Society,
Super
and
great time talking about DOAC and pediatric, especially with the international approval from European and FDA as well, and Canada and Japan. They all now approved DOAC, especially rivaroxaban and dabigatran, based on the recent data from the phase 3 trial. Okay, yes. So I have no direct financial disclosure. So talking today about the major difference between pediatric and adult venous thromboembolism for sake of the audience and the current available treatment for pediatric thrombosis, as well as the new evidence that's coming up in pediatric, particularly the completed phase 3 trial. Some practical consideration when you patient on DUAC. So what's the major difference between adult and pediatric for venous thromboembolism? It's almost everything. Epidemiology is the extreme. In pediatric, it's very rare. In adult, so it's pretty common. And the level of evidence in adult is one of the most extensively treated, and trial has been done on, especially randomized control trial in pediatric, in adult venous thromboembolism. As when pediatric, we only have very limited randomized control trial, very low number, below 100 patients has been involved in randomization for pediatric thrombosis, and all the guidelines has been published. It's based on this limited number, and the observational study has been published. Physiology is quite a big difference from the infants, adult, from the consumption and the concentration of the factors and platelet phenotype, as well as the response of treatment. Diagnostic strategy is different in pediatric. Ultrasound is good for lower limbs, but in upper limbs, which is the most common VTE in pediatric, it can be challenging, especially when you go behind the clavicle. Imaging and contrast is a limitation, especially when you want to give contrast and sedation is required. So it's a quite challenging the diagnostic as well. Pharmacology, mainly the pharmacokinetic and dynamic in pediatric is quite different from adult, and that's what has been shown in phase 3 and phase 1 and 2 trials for diversity for dabigatran and Einstein Jr. for rivaroxaban. We'll talk about it a little bit more. Interpretation for monitoring testing in pediatric, we really don't have any studies targeting the target. How much should we go for PTT or even factor anti-10A. There is no validated predicting factor for pediatric, and the outcome of interest is quite different. We don't only fix what's broken. We really would like to unlock the potential for the kids. We treat the kid, we don't know the kids, how is he gonna be? Is he gonna be an artist? He's gonna be a musician or a long-standing surgeon. So you really need to work on unlocking this potential for the kids and treating the patient as a whole, with the family, with the struggle, with the psychosocial trauma, with the needles and everything is quite challenging. So epidemiology again. Yeah, we know adult in the venous thromboembolism, it increased the incidence with age, but when you highlight the very rare, the small kids from the history down from the It's from the first. It's from the first Canadian registry for pediatric thromboembolism, and you see the two peaks in infancy is mainly related to sorry for technical. So it's a two peak in infancy mainly related to the highest peak in infancy, mainly related to critically ill neonate and central line clots, and the other peak is in teenager females with hormonal therapy and so on. And to be more realistic, as a pediatrician in Saudi Arabia, we're treating the neonate, and adult hematologists, they are treating the 14 and more. So we are really practicing more with very small infants, and this is the first study registry, and many registry has been published from Netherlands, Sweden, and UK and state as well. Shows dramatically increase up to threefold in last 2 decades, mainly due to advances in critical care and the use of central line again. And we see central line is the most common cause, up to 80% in our practice. Very rarely we see idiopathic comparing to adult that reach up to 40% adult. We see very rarely. I think in our practice is less than 10 to 5%. Pharmacokinetic and dynamic is pretty important, and we really need to be focused on, and as absorption and distribution, metabolism, clearance of the drugs are affected by direct age. Kidney maturation play a major role, especially when determining the safety and the effectivity of the dosage that renally excreted. DUAC, most of it, or a part of it, it's renally excreted. So we really need to be careful about this. So the goal of the treatment in pediatric and adult is overlap. We really want to fixate the thrombus and prevent it from progression, and prevent embolization to vital organs, and prevent the recurrence as well. Post-thrombotic syndrome is very important to highlight on, assuring the good quality of life. Though effective treatment is very important to prevent significant association between significantly associated morbidity and mortality related to clots. The recurrence rate is although it's low, but it's mainly with hits the most commonly, and go down a little bit when you have a homozygous genetic mutation and some double heterozygous, a little bit less. Antithrombin deficiency is linked to high incidence of recurrence. Unprovoked clots a little bit less, but provoked is very rarely to have a recurrence. So you would question yourself, do you really want to secondary prophylax the provoked clots? This is our current available treatment. Most of them is not approved in Saudi. Unfractionated heparin, low molecular weight heparin, and vitamin K antagonist. Unfractionated heparin required infusion, mainly this very critical ill, multiple POCs for detecting the PTT, and we really need to acknowledge the risk of HIT. HIT is extremely rare, but I think in Saudi we see it more than other population. Low molecular weight heparin is very popular, but still very traumatic injury to the family and to the kids, and the dosing is a pain. When it came with adult dosing, and you want to give the 3 kg with the 40,000 international unit. It's really hard, and especially with the nurses in the ward, it's difficult. Vitamin K antagonist is a potential for drug interaction and food-drug interaction, especially with reopening school. The kids is re-entering a new diet, so you really need to do a frequent INR follow-up. We don't really have a study for INR in kids, and still in the pills, no suspension. This is the wish list that we had. We're really lucky to have right now with selective 10A inhibitors and thrombin inhibitor for dabigatran, and for 10A is the rivaroxaban, apixaban, and endoxiban. Pros and cons. Pros is very rapid onset, no needle requires, predictable, non-antithrombin dependence, fewer drug interaction, and short half-life. Short half-life, you can take it as a pros and cons as well. Cost is no-brainer. Warfarin is a winner, and potential for overuse, especially when you look to the studies, like 16 kg with the dabigatran and 60 kg and 16 years old and 30 years old 60 kg is different dosing. In adult they are fixed dose 150, and we give in pediatric is 350. It's a little bit iffy. So what's the evidence right now about the pediatric thrombosis, DUAC in pediatrics? So the current pediatric investigation plans for DUAC is three categories. Is the prevention, the primary prevention, which is mainly apixaban study runs by COG, randomizing apixaban versus placebo. And surprisingly, the late breakthrough abstract from ASH this year has been withdrawn by the author. So it's a concerning issue, to be honest. Britenixaban is a neonatal and still ongoing, but apixaban COG study is already closed, and we expected to see the result shortly. Prevention of cardiac and arterial thromboembolism, post-Fontaine for rivaroxaban and or apixaban in many cardiac disease, still ongoing studies. Mainly, our target is the acute treatment for DVT, and rivaroxaban and dabigatran is the completed phase 3 trials. Dabigatran is interesting one with diversity study. They looked into acute VTE and extended, and they have continuation as extended secondary prophylaxis. So these are the completed trials for rivaroxaban and dabigatran, and you see the huge number comparing what we have historically. So the first pharmacokinetic study from Einstein Junior program, it's a single arm multicenter phase 2, included 93 patients, children, and only 10 kids below infants below 6, and the junk was from 6 to 11 years old. Shows no recurrence of VTE, no major bleeding, and only 3 females with a teenager with menorrhagia. And concluded the drug is safe, but they highlighted children below 12 years old, 12 kg had a low drug exposure, and that's led to TID dosing in phase 3 study. So phase 3 study for rivaroxaban randomizing 2-to-1 to standard of care with parenteral anticoagulation therapy, 5 to 9 days. They recruited 500 children and 335 for rivaroxaban arm. And again, 0 to 2 years old is the minority of the study, and the big chunk, almost around 184 is a teenager above 12 years old. And the median follow-up was 91 days and 30 days on the infant group. The recurrence was 1% for rivaroxaban versus 3% for standard of care, and major or clinically relevant non-major bleeding, 3% for rivaroxaban versus 2% of standard of care. This study not powered to demonstrate non-inferiority, but FDA and EMA agreed to accept this number and explorate data from adult. 2 sub-analyses from Einstein Junior, one for central line venous clots, 126 patients included in this study. It's a very low number comparing to our practice, only 25%, and rivaroxaban is 90 patients on rivaroxaban, and it shows very good, no recurrence, 90% complete resolution of the clot, no major bleeding, and concluded that the drug is safe for symptomatic and asymptomatic catheter-related clots. Another sub-analysis for sinus venous thrombosis is 114 child with sinus venous thrombosis included in the study. It's a huge number looking to our practice, comparing to our practice, and again, favorable outcome for both standard of care and rivaroxaban. Dabigatran is a diversity program for randomization control. This open label phase 2 and 3 non-inferiority trial included 267 child randomized, 177 dabigatran and 90 to standard of care for 3 months course of therapy. Interestingly, this study, the criteria was to patient may get parenteral anticoagulation therapy up to 3 weeks before initiation the dabigatran, and the medial duration for the initiation of anticoagulation therapy was 15 days. And when you look to the sub-analysis, you found 17% only had line-related clot, 9% CVT, and 9% is PE. The rest is VTE. And the result shows that the major bleeding is 2%, and the non-major bleeding is 1% in both arms. Looking to the composed primary endpoint, completed the resolution of the clots, no recurrence, freedom from recurrence, and freedom from venous thromboembolism related death, and it's clearly statistically significant. It shows non-inferiority, provide the non-inferiority for dabigatran comparing to the standard of care. So the continuation study for secondary prophylaxis for dabigatran led by Leo Brindau. It's an open label single arm for secondary prevention up to 12 months. And they included patients with VTE and completed 3 months standard of care therapy. And they included more than 200 patients. Only 8 patients is 0 to 1, the infants, and the big chunk is again from the teenager above 12 years old. The median duration was 8 months. Major bleeding was 1.5%, and non-relevant, non-clinically relevant bleeding is 1%, and again, recurrence is only 1%. So as a summary from phase 3 trials for rivaroxaban and dabigatran, it's very encouraging. The rate of recurrence is very low. The bleeding is low in both trials. But the big question here is, does this reflect the real world data? I'm not really sure. It's very restricted inclusion criteria. Very few infants involved with central line as well. Patients who were critically ill not involved in this study as per people in the studies, and still there is no liquid formulation. And in a market, Zertello is promised that it will be early 22 in a market, but still it's not in the market. So now we just get a question, and the consult is not to treat the clots, it's can we start DUAC? And it's pretty tricky. Very slippery surface, so it's a direct consultation now. So I have a quick list. I go through, like it's a quick list, just quickly. I ask myself before saying, oh, I might go or not for DUAC. Is patient stable? This is the most common consult from ICU. They don't want to give us sub-Q or follow-up. They don't want to follow anything. So you just, okay, let's go do DUAC. No, we cannot do DUAC for patients in ICU, at least from my point of view. Anything can happen in ICU. So we leave it to when the patient just before going home, so the patient taken orally well. We know rivaroxaban need to be taken with a meal for better absorption. Can be given via NG, yes, you can crush it, but dabigatran, you cannot open the capsule and put it in an NG because the bioavailability will increase 75%. You will get into trouble with that. How much of the old, how old and the weight of the kids. It's about the pharmacokinetic and diuretic and the renal excretion. Small kids need TID in some drugs, and the big kids need only once daily, close to the adult dosing. Renal function is important. We try to avoid rivaroxaban and DUAC in people with kidney disease, as we know from adult data, is associated with high risk of bleeding. Renal creatinine clearance is very important. You would want to start DUAC with less than 30. Any other drugs? Yes, there is a few drug interaction with drugs, some azole, some antibiotics. So you really need to consult your clinical pharmacist and patient on multi-drugs. do they have acute IBD, protein losing enteropathy, recent GI or GI protein? We know the absorption is for DUAC is in stomach and proximal gut, so you would be concerning about these. If you think your patient has an antiphospholipid syndrome, even if you think you shouldn't start till you get the result. We know rivaroxaban increase the risk of thrombotic events with antiphosphotic syndrome, and if you started, good luck, you will have false positive testing. Do they have intrauterine bleeding? Many result from adult data and even Einstein Junior study that rivaroxaban increase the risk of intrauterine bleeding. Many experts and centers now moving female teenager who was administering to apixaban rather than starting rivaroxaban. When to stop before surgery? This is with the permission from my colleagues. Leo, this is a McMaster adult diagram for rivaroxaban based on bleeding risk, for dabigatran based on bleeding risk and creatine clearance. 1 to 4 days maximum. You can stop it. You can just see it. Reversal in pediatric, mostly we get away with conventional and standard of care support. Very few case report using idrasozumab for targeted dabigatran, and recent case report for adenosine alpha for patient on rivaroxaban, factor 10A inhibitors with patients from SHOP with intracranial hemorrhage and medial line shift and successfully treated. For idrasozumab, pediatric trial has been closed due to low recruitment, and for adenosine is still planned. Both are FDA approved. As a conclusion to my talk, we are entering the DUAC era for pediatric thrombosis, and I think if we have thoughtful and careful use for these drugs, we can have tremendous advantage over the standard of care. We really need to educate pediatric and adult as hematologists as they treat as an adult, but actually the studies it's a big. This study to me is for 14 years and more. I think if I feel comfortable to treat above 50 with these results, but below 30 kg, I would be very concerned. I will be. It's a little bit tricky. We need more real-world data, the outcome, adherence about the drug, a special population. Pediatric oncology is very important with low platelet count, with going to OR frequently, and LP with a bone marrow. So we don't know when to stop, when to restart. And I think we really need to hear the results from the studies. Infant and if you treat thrombosis, you know, we treat mostly infant and CDC related clot. Reversal outcome, we don't have good data, it's only case report in pediatric. And still it's not approved in pediatric in Saudi Arabia. Saudi FDA is not approve it. I don't know. So if we don't have a good monogram to treat and dosage by the authority, I think it should be very careful using these drugs right now. Until here, so thank you very much. I hope you like it. اي خلاص شكرا.
Thank you, Dr. Badr, for the nice talk. And I think Prof. Al-Alfi with us from Egypt online. He's going to introduce the next speaker. Is that right?
Good evening, everybody. It is my honor إني أحيي الأستاذة الدكتورة عزة الزهراني من القاهرة قلب العروبة لجدة عاصمة الثقافة والطب. يا ريت يكون صوتي واصل، وبحيي الدكتور بدر على البرزنتيشن الهائلة، ويسعدني ويشرفني إني أقدم الأستاذ الدكتور أمال بشلاوي. الدكتور أمال بشلاوي رحلة عمر طويلة أكثر من 30 سنة تزامنا. She is my senior. She graduated from Cairo University and she has training in Paris. And she is the president of two very prestigious societies, the Egyptian Thalassemia Society and the International Society of Pediatric Hematology and Research. She is a PI in more than 50 projects, and she has more than 250 publications in New England Journal Hematology, Blood Hematologica, very prestigious, and she has a lot of activities. Professor El-Bishlawi will give us an important talk today, and it is my honor to introduce Professor Amal. Her talk will be on COVID and hemoglobinopathies, and this is an overwhelming topic, the COVID, and I am very happy to be among these prestigious attendees, speakers and chairpersons from Cairo, and they are in Jeddah in the COVID era. I hope it will finish soon. Professor Amal Bishlawi. I hope Professor Amal is ready. Till Professor Amal is ready. Okay, that's great.
COVID-19 and hemoglobinopathies. This is my disclosure. This is the agenda. I present the era of COVID-19 pandemic. Are patients with hemoglobinopathy more susceptible to acquire the disease? Impact of iron and chelation therapy on COVID-19 infection in thalassemia. Sickle cell disease and COVID-19 infection. Highlight on Arab countries. Spleen status and virus vaccine. What about? And the conclusion. Compared to the general population, patients with hemoglobin disorders such as sickle cell disease or thalassemia are expected to be more severely affected by COVID-19 due to the pre-existing chronic morbidities. This is what is TIF presented and right in 2020. The implication of SARS-CoV-2 infection in thalassemia. Do patients fall into the high clinical risk category? Very few cases in thalassemia have so far been reported. No evidence between iron chelation and susceptibility to SARS-CoV-2 or infection or COVID-19 severity. Beta thalassemia may protect against COVID-19. In Italy, Ferrara, with this high number of inhabitants, very few high incidence of thalassemia, which is the third place most affected in Italy, where the carrier rate is 8%, they were very resistant to COVID-19. Only 500 cases have been identified. At the same time, Italy counted more than 335 deaths and high cases of COVID-19 positive. Data from multi-center study on COVID-19 in hemoglobinopathy, a total study by Vincent and in the Mediterranean Journal of Hematology, a total of 17 cases of 10 countries following 9,499 patients participated in this survey. The outcome data reported a total of 13 patients were identified. 7 thalassemia major, 8 thalassemia intermediate, and 3 with sickle cell disease in 6 centers. The overall mean age was 33 years. The number of patients are very few to the total number which has been screened. COVID-19 beta thalassemia, if they are subjects immunized, this is what is Lanzio reported or studied. Analysis of the evolution of COVID-19 infection in 3 Italian regions, Belgium, Sardinia, where the carrier rate is 12.9%, Sicilia, with different beta thalassemia heterozygotes, population prevalence is correlated to immunity against the virus. In another Italian report by Matta, he wrote the number of infected thalassemia patients was lower than expected. SARS-CoV-2 infection in patients with beta thalassemia, this is experienced from Lebanon by Dr. Ali Tahar and his co-authors. From February 2020 to April 2021, 40 cases of beta thalassemia and COVID-19 were reported by the Chronic Care Center, diagnosed by real-time PCR. The mean age of the patients was 30 years. The range was from 9 to 61 years. 67% had transfusion-dependent thalassemia and 32 had non-transfusion dependent thalassemia. Current data from the literature reporting outcomes of beta thalassemia patients with SARS-CoV-2 infection are very limited. In this report, they investigate the severity of COVID-19 among beta thalassemia patients who are regularly followed up in the Chronic Care Center, a tertiary care thalassemia center in Lebanon. And this is a table showing the demographic data and the clinical characteristics of beta thalassemia patients infected with CoV-2. The age is around 30.7 years, and actually the COVID-19 disease severity showing asymptomatic or mild in 80% of the cases. Moderate cases, only 4 cases presenting 10%, and severe or critical, 4 cases or 10%. This is another study from Egypt. The prevalence of COVID-19 in Egyptian children with hemoglobinopathies and inherited anemias by Dr. Ismail. This is a cross-sectional study evaluating data from 258 children with hemoglobinopathies and inherited anemias in Ilmenia Governorate in Upper Egypt. Data collection by questionnaire and appropriate investigations including PCR, serum antibodies for COVID-19, and chest CT scan. The results showed that 38 patients, or 14.7%, had mild to moderate infection. No one case with severe infection. Cases were older, 63.2%, non-compliant to ion chelation therapy, with 78% did splenectomy. Coming to the chelation therapy and thalassemia, the impact of ion and chelation therapy COVID-19 infection in thalassemia. Should thalassemia patients continue ion chelation if they are exposed or have COVID-19? This is showing the pathogenic effect of COVID-19. There is direct damage of hemoglobin molecules. Hemoglobin consists of 4 globin subunits, 2 alpha and 2 beta chains. Each subunit is attached to heme, which has 2 main components, iron and porphyrin. SARS-CoV-2 attacks one of the beta chains of hemoglobin, leads to dissociation of iron from heme. This leads to increased free iron level in the body. This can explain why most of the patients with COVID-19 have high level of ferritin. Pathogenesis of COVID-19 Possible treatment with iron chelation. Free and bound iron possibly contributes to the hypercoagulation and inflammation found in severe COVID-19. The non-apoptotic immunogenic cell death, which is called ferroptosis, a potential contributor to the pathogenesis of COVID-19. Lactoferrin and levodopa, deferoxamine, and other iron chelators may provide a high therapeutic value. Could iron chelators prove to be useful as an adjunct to COVID-19 treatment regimens? Iron chelation and RNA viruses. Deferoxamine decreased viral replication of some RNA viruses, and when it was combined with antiviral drug, it led to synergistic effect on reducing the virus replication cycle. The role of iron in pathogenesis of COVID-19 and possible treatment with lactoferrin and iron chelators. Deferoxamine and other chelators have immunomodulatory effect, ameliorating viral-induced lymphopenia and improve clinical outcomes. Iron chelator and COVID-19 infection. Iron chelation have been beneficial adjuvant therapy in treating COVID-19. Iron chelators, such as deferoxamine, may prove to be effective in the fight against COVID-19. They may have a role to play not only with sequestering iron and alleviating inflammation, but also in preventing the coronavirus from binding to the receptor it utilizes to enter into the host cells. Chelation agents exhibit antiviral and immunomodulator effects in vitro and in vivo. It inhibits viral replication, decreases iron availability, upregulation of B cells, improvement of the neutralizing antiviral antibody. It inhibits endothelial inflammation, prevention of pulmonary fibrosis via reduction of pulmonary iron accumulation. Pathogenesis, iron and pathogenesis uncovered role of iron chelation. Increased iron level induces the release of the endothelial inflammatory cytokines interleukin 6. Through its iron chelation, deferoxamine reduces iron availability in serum and body tissues, which could prevent lung injury and fibrosis following COVID-19 infection. The role of iron in the pathogenesis of COVID-19 and possible treatment with lactoferrin and other iron chelators. This is showing you how coronavirus enter into the cell. Enter into the cell through a receptor. This receptor have been helped by the adhesion factors here. These adhesion factors facilitate its entrance by the receptor and augment the number of coronavirus to enter into the cell. Here, lactoferrin of the iron chelator is going to act as a prevention mode or prevention site to prevent the entrance or adhesion of COVID-19 into the adhesion molecule and preventing its entrance through the receptor into the cell. And this will minimize the entrance of the COVID into the cell of the patient. Sickle cell disease and COVID-19 infection highlight on Arab countries. This is COVID-19 and sickle cell disease in Bahrain. COVID-19 is caused by a newly identified strain of coronavirus family which affect the hemoglobin beta chain. Study was undertaken to see if COVID-19 infection increased disease severity in patients with sickle cell disease by mass screening of the Bahrain population. A total of 38,000 were tested for COVID-19, where sickle cell disease patients, 6 patients with sickle cell disease have COVID-19, presenting 1.6% of the total. 3 remained asymptomatic, 2 had mild symptoms, and 1 required oxygen therapy. So the conclusion of the study, the infection rate, clinical course, and viral clearance seen for sickle cell disease patients were not different to those without sickle cell disease. Sickle cell disease in Bahrain is caused by a newly identified strain of coronavirus family which affect the hemoglobin beta chain. This is another epidemiological characteristics and outcome of children hospitalized with COVID-19 in Oman, which is a multi-center cohort study. A multi-center retrospective study of children hospitalized with COVID-19 less than 14 years in 7 centers across Oman between February and July 2020. 22 or 39% had a medical condition, of whom 13% or 7 cases had sickle cell disease. Most of the children had mild cause and satisfactory outcome. This coronavirus infection in children with sickle cell disease from another study from Oman, a report of case series of 5 sickle cell disease Omani children infected with COVID-19, all cases are completely recovered. And this is another study from a developing country from Brazil, where only 10 patients tested positive for SARS-CoV-2 of 600 patients, 8 needed hospitalization. Even in middle-income countries, COVID-19 was reported to be relatively mild in sickle cell disease patients. COVID-19 and sickle cell disease favor the occurrence of thromboembolic events. In Europe and USA, cases reports of sickle cell disease patients with COVID-19 was surprising, considering the susceptibility of sickle cell disease patients to infection and vaso-occlusive complications. Actually, there is no action or patient have been affected by increase in thromboembolic manifestations. And they found that blood type O seems to confer some protection against severe COVID-19. Care of patients, Ali Tahar and his co-authors published Care of Patients with Hemoglobin Disorders during the COVID-19 pandemic, an overview of recommendations. Healthcare professionals should differentiate between pneumonia and acute chest syndrome, where more diffuse ground glass appearance is commonly associated with SARS-CoV-2 infection. Patients manifesting fever and cough, worsening of anemia, early aggressive, simple or exchange transfusion should be done. No evidence that being an hydroxyurea should increase SARS-CoV-2 infection. Hydroxyurea with sickle cell disease was a point of discussion and investigation. In the absence of regular blood transfusion therapy, hydroxyurea will decrease the incidence rate of vaso-occlusive pain and acute chest syndrome events. Low-dose hydroxyurea is recommended in all pediatric patients with sickle cell anemia who receive regular blood transfusion therapy for primary or secondary stroke prevention. All adult or pediatric sickle cell disease patients with severe COVID-19 should be given prophylactic doses of anticoagulation. Blood tests on admission should include platelet count, fibrinogen, and D-dimer levels. Spleen status and virus vaccine. What about in these patients? Splenectomy in thalassemia. Are thalasssemic patients with splenectomy more prone to COVID-19 infection? No evidence to prove that splenectomy is associated with an elevated risk of SARS-CoV-2 viral infection compared to general population. Patients who do the splenectomy must be evaluated for bacterial infection. Splenectomy is not known to increase risk of viral infection. Vaccination in patients with hemoglobinopathy. This is a very important, debatable, and commonly asked by the families. Vaccination for patients with hemoglobinopathies should be a priority within a national vaccination program. All adults with sickle cell disease This should have the priority. Thalassemia patient with severe iron overload, patient with one or more underlying morbidities, including diabetes, pulmonary hypertension, endocrine, cardiac, and respiratory diseases. So the conclusion, patients with hemoglobinopathy are not more susceptible to COVID-19 viral infection. Iron status and chelation therapy can have a role in the pathogenesis and management of viral infection. No evidence of increased vaso-occlusive or thrombotic events in sickle cell disease patients and COVID-19 viral infection. Exchange transfusion and hydroxyurea are supportive treatment for sickle cell disease patients, adult and pediatric, when indicated. Patients with hemoglobinopathy should receive corona vaccine. And thank you all for attendance, and this is one of the patients looking for a more prosperous future. And thank you again for your kind attention.
Thank you. Thank you all, the speaker. And we have 5 minutes. If there is any question, please, for any one of the speaker. I can ask Dr. Al-Hayani about the DOACs in children. As you know, there is many centers, they are not doing the level for low molecular weight. They don't have anti-10A level. And also in the private hospital. Could, if we prescribe for them like the DOACs, which is approved for pediatric, which, as you know, they don't need a level, is that safer and another option?
So the issue with all the DOAC, you cannot start it initially because there is no data that you start DOAC initially. So you really need at least 5 days for prior to start in Rovaroxaban or like a few weeks prior to Dabigatran. So there is no. So I think this is the concept that we really need to be aware that you can't just jump to start with DOAC. And I think this is the people is really now rushing. DOAC is good. DOAC is encouraging the results. Should we just start DOAC? Yes, fair enough. But I think low molecular weight heparin or unfractionated heparin should be the first step. Then you ask yourself the quick: is this patient is suitable for DOAC or not? So I think it's a luxury to have DOAC right now, and especially with testing. I just want to highlight: you don't need to follow DOAC. You don't need to track your coagulation workup, but you really need to know about the disturbance for coagulation workup, the PT, PTT, and INR because of DOAC. It doesn't cause coagulopathy, but it changed the numbers on the test. So there is impact on the test. So you really don't need to catch up your numbers because the DOAC is affecting the numbers. So we are seeing this actually pretty recently, that people starting DOAC and see very high PTT and just jumping with FFB or high PT and giving factor 7. I think this is very, very, very important to pay attention to. That's coming to our job to raise more education about DOAC, how to use it, when to use it.
Yeah, I agree. I think it needs a little bit time to be comfortable to use it in pediatric age group.
Yeah, I think we need to work to use it more so we can gain experience, and if we come all together and share our experience, and this is how we're gonna learn about DOAC.
Thank you, Dr. Hayani.
Thank you, everyone.
Okay, Dr. Ali.
Professor Badr, it was very interesting presentation, excellent presentation. I'm not sure if there is more questions for Dr. Badr or not. For Azza?
There is one question from Dr. Ali.
Yes, just a quick question. I think it's an exciting time for the DUAC, and practice in medicine is based on evidence-based. And children, if you look at what we are using right now, the warfarin and the enoxaparin, there's no evidence of phase 3 in children. It's all extrapolated from the adult data. And on the other hand, now we are seeing at least a couple of the phase 3 trial, which is the one that's shaping the clinical practice. So I think it's people are anxiously awaiting the ECB guidelines, where actually they put the evidence and put the recommendation based on the current evidence. But I think probably in the next couple of years, probably the more people that will be using the DUAC, and the question at that time or now and on is probably when not to use it, because people will be utilizing it more and more. And once the guidelines or and the recommendation from the different consortium starting to put that in, which would be nice for the family, but it's we have to utilize it carefully for the indication that not yet been approved for.
Yes, we agree.
Yeah. So I just have one comment. It's a pretty interesting discussion. If you look to all guidelines for chest, ASH, and everything, it's most of all of them is conditional recommendation, and I believe the field of pediatric thrombosis is a personalized medicine. It's not a straightforward is one-on-one. It give you two, and I think every case you should take into consideration. And I agree with you. It's all about when to use, when not to use, and I think it's case per case. And in general field of pediatric thrombosis, as you see, there is no hard, even the first 3 trials, it's not really representative of the real world. And if you see, and even rivaroxaban phase 3 it wasn't powered for non-inferiority study. So it's still, we don't have the solid floor to stand on. And I think the key is to practice, the key is to get more data. But with really careful and thoughtful use in case by case. Okay.
I have one question for Prof. Amal.
Thank you.
First, thank you for very nice comprehensive review for COVID with hemoglobinopathies. My question for you, Prof, that if the pediatric sickle cell disease admitted with COVID positive, and they found their D-dimer is not that high, is there an indication to start them in prophylaxis, DVT prophylaxis? Are they higher risk to get thrombosis than non-sickler?
Very good question. Yes, you can give him a prophylactic dose of anticoagulant in cases of sickle cell disease. This is for adult and pediatrics. This is really what we have to do, prophylactic dose of anticoagulant.
Thank you.
I have a question.
And this depend, and actually it depends on the D-dimer level. If there is a high D-dimer level, I have to give the full dose of anticoagulant. If it is not, I have to give prophylactic anticoagulant.
Okay, clear, thank you.
I have 2 questions. One for Dr. Amal. Thank you so much for your presentation. Regarding the blood transfusion indication in the sickle cell anemia with severe COVID, in the absence of the clinical finding like acute chest syndrome and anemia and laboratory, do you think this is an indicate for blood transfusion for patients with sickle cell anemia with severe COVID infection?
I think this depends on the level of hemoglobin. If the level of hemoglobin is low, I have to give him blood transfusion. If his hemoglobin is okay, he will not benefit so much from giving him blood transfusion. So it depends on the level of hemoglobin. And you know that COVID causes anemia, and COVID in particular affecting a beta chain, a beta globulin. In sickle cell disease, there is affection, substitution of the amino acids. In thalassemia, it is defect of the beta chain. If there is anemia, I have to give blood. If there's no anemia, no need for blood.
Thank you, Doctor. One question for Dr. Najla regarding TB53. I have the patient standard risk ALL. And when I did cytogenetic, I found this is a TB53 positive. There is any suggestion or any role to be take the action with this patient?
You mean the somatic mutation of TB53? In this case, we have also to do a germline mutation of TB53. When you check for hypodiploidy by fish, and it's completely negative. Yeah, I think this is one of the indications that we have to check for germline mutation of TB53.
If there is no questions, Dr. Azza from the floor, I have a question for Professor Al-Bashlawi. In our experience in Ain Shams, we didn't find cases of multi-system affection, COVID affection, MIS-C, among the thalassemia or sickle cell anemia. Is it the same experience in the thalassemia, huge thalassemia clinic in Cairo University?
Yes, it is exactly the same. We didn't find very sporadic cases, we find, but there is no lot of patients at all. And even these patients who acquire COVID-19, they recover very, very easy without any admission to the hospital or to the ICU or something like that. Have the same experience. We have got the same people.
It's true, the same experience.
Yes, yes.
Dr. Azza, do you have any questions from the floor?
No more question.
I would like to thank Dr. Azza. Before we finish, I would like to thank you for this opportunity to thank Professor Amal Al-Bashlawi with excellent presentation on COVID-19 among homoglobinopathy population. Thank you.
Thank you. Also from our side, we would like to thank you both Prof. Amal Al-Bashlawi, Prof. Mohsen Al-Alfi joining us from Egypt. Thank you very much. And thanks for all the audience and all the speaker, Dr. Hayani, Dr. Najla Al-Imam. Thank you very much. And we close the session. Thank you.
Before closing, Dr. Azza, I would like to thank very much the Saudi Society of Hematology and Saudi Society of Bone Marrow Transplantation. It is our great honor to be included, and we are very sorry that we couldn't come in this our beloved and very near heart country. Thank you very much.
Thank you.